Now we are going to discuss burns and plastic surgery. First, we are going to discuss the one-liner questions which are asked related to causes of death in burns. So first question, what's the most common cause of death at the site of burn or at the site of accident? And it is because of what? Asphyxia. It is because of asphyxia. What is the most common cause of early death in burns? And you know, it is because of hypovolemia or shock. So the most common cause of early death in burns, it is because of hypovolemia or shock. Why? Because there is fluid loss. Generally, there is third space loss. After that, what's the most common cause of late death in burns? And this late death is because of sepsis. It is because of sepsis. Suppose there is a question that overall, what is the most common cause of death in burns? Overall, the most common cause of death in burns is sepsis, right? And whenever we are doing dressing in burns patient, generally at the end of first week or during second week, what the color of dressing becomes green. So what is the most common organism responsible for sepsis in burns? And you know, it is Pseudomonas. It is Pseudomonas. Now see, what are the various degrees of burns? On the basis of depth of burn, burns are divided into 4 degrees. This is also known as burn classification. So according to burn classification, there are 4 degrees. What is first degree? In this you can see that there is involvement of epidermis only. So what's the other name of first degree burn? This is also known as epidermal burn. What's the other name? It is also known as epidermal burn because only epidermis is involved. What is a classical example? When you are going to touch any hot object, like when you are ironing your clothes, you are going to touch the hot iron, you are going to touch some hot object, and suddenly you are going to remove your hand. So what happens? You are going to notice at the site of burn there is a red line, but there is no blister. So what? It is erythematous, it is painful, there are no blisters, and you must be knowing healing occurs without scarring within 5 to 10 days. So description of epidermal burn, yes, it is involving only epidermis, there is erythema, it's painful, there are no blisters, and healing occurs without scarring within 5 to 10 days. Healing without scarring within 5 to 10 days. Okay. Then there is second degree burn. In second degree, you can see apart from epidermis, there is involvement of dermis. Second degree burn is also known as partial thickness burn. It is further divided into superficial partial thickness burn and deep partial thickness burn. Okay. Now see, superficial partial thickness burn, it involves epidermis and which part of dermis? Papillary dermis. And in deep partial thickness burn, there is involvement of epidermis plus reticular dermis. Classical example, suppose there is spillage of hot water, hot milk. After that spillage, what you are going to notice? You are going to notice that there is development of blisters. It is painful also, and healing occurs without scarring within 7 to 14 days. That's characteristic of superficial partial thickness burn. So see, what are the differences between superficial partial thickness and deep partial thickness burn? So we discussed in superficial partial thickness burn, there is involvement of epidermis plus which part of dermis? It is papillary dermis. Okay. Papillary dermis, right? So here blisters are present, it is painful, so there is presence of blisters, it is painful, and here healing occurs without scarring. In how many days? You have to remember, in 7 to 14 days. Right? Now see the differences. In deep partial thickness burn, at the place of papillary dermis, there is involvement of reticular dermis. So epidermis plus involvement of reticular dermis. Blisters are present in superficial partial thickness burn, but these are absent in deep partial thickness burn. Here it's painful, here there is no pain. Deep partial thickness burn, no blisters, no pain, but pin-prick sensation is preserved. There is pin-prick sensation, right? And what's the appearance? If you have seen a patient of deep partial thickness burn, you have noticed that the burn surface is mottled. There are whitish areas, there are pinkish areas. The wound surface appears white and pink. It's mottled, and here healing occurs with scarring. It takes 3 to 9 weeks. So healing occurs with scarring, and how much time it's going to take? It's going to take 3 to 9 weeks. Now see this third degree burn. So apart from epidermis plus dermis, there is involvement of subcutaneous fat. This was the question which was asked many times in NEET and DNB. Involvement of subcutaneous fat in third degree burn, and this third degree burn is also known as full thickness burn. It's also known as full thickness burn. What's the appearance generally? Whenever you have seen this patient, generally there is black colored leathery eschar at the site of burn. Sometimes in the limb, if this eschar is circumferential, what's the problem? Patient is going to develop compartment syndrome. So apart from management of burn, management of hypovolemia, we have to perform the escharotomy. Otherwise, it will lead to compartment syndrome. So what's the appearance? This patient is having black colored leathery eschar at the site of burn. And if this eschar is circumferential, to prevent compartment syndrome, what we have to go for? Escharotomy. Here it's full thickness burn, so there is no pain, no blisters, no pin-prick sensation. And in such patients, healing occurs with contracture. Okay, flexor surface is involved, so you have seen patients of contracture. So healing occurs with contracture. And how we are going to prevent the contracture? Yes, when the patient is coming to us after fluid resuscitation, we take the patient to OT, excise the burned skin and go for skin grafting. So how to prevent contracture? For this, excise the burned skin. So we have to go for excision of burned skin, okay, plus skin grafting. So this is how we are going to prevent the contracture. This is third degree burn. What is fourth degree burn? In fourth degree burn, apart from the skin, there is involvement of underlying structures like muscle, bone or brain. So in fourth degree burn, apart from skin, there is involvement of underlying structures like muscle, bone and brain. Clear? So it's very easy to remember the classification on the basis of examples. First degree, when you're going to touch any hot object, there is erythema, there is pain, no blisters, healing occurs without scarring within 5 to 10 days. Superficial partial thickness burn, it's because of spillage of hot liquid, hot water. There is blisters, it is painful. Again, healing occurs without scarring within 7 to 14 days. In deep partial thickness burn, healing occurs with scarring. It takes 3 to 9 weeks. In full thickness burn, that's third degree burn, there is contracture. In fourth degree burn, apart from skin involvement, there is involvement of underlying structures like muscle, bone or brain. Now see the important points related to management of burn patients. So whenever these patients are coming to our emergency, apart from starting fluid resuscitation, we have to look for danger signs of airway burns. So if the patient is having burns involving face, head and neck, if there is singed or burned nasal hair, there are carbonaceous deposits in the sputum, there is hoarseness of voice, or there is history of burns in closed room, in all these patients, we have to suspect the airway burns. Okay, and in the patients in whom we suspect airway burns, what is the safest approach? Go for elective intubation. So if we suspect airway burns, what is safest? Elective intubation is safest. Okay, why? Suppose there is airway burn and you are not going for elective intubation. If there is delay, what's the problem? There is laryngeal edema, and if there is laryngeal edema, it's very difficult to perform the intubation. So if patient is already having laryngeal edema, there is delay in intubation. In such patients, we have to go for emergency cricothyroidotomy. So important point, if delay is there and patient developed laryngeal edema, right? In such patient, what we have to go for? Emergency cricothyroidotomy. Cricothyroidotomy. Okay, so what's the safest? Elective intubation. If the patient develops laryngeal edema, go for emergency cricothyroidotomy. Now see the important questions related to fluid resuscitation. You must be knowing what is the fluid of choice for resuscitation in burns. It's Ringer lactate. Okay, and if in the question is asked maintenance fluid of choice in burns in children, the maintenance fluid of choice in children should include dextrose. So it is DNS. What? Dextrose normal saline. You have to remember. Dextrose normal saline, right? And the patients who are having burn shock, in such patients we are giving hypertonic solution. So what's the fluid here? Here we give hypertonic saline. Okay, we give hypertonic saline. So how we are going to calculate the fluid requirement? Most commonly used formula for fluid requirement in burn patient is Parkland formula. What is this Parkland formula? It's the 24 hours fluid requirement in ml, and it is 4 into body weight in kg, 4 into body weight in kg into percentage of burnt surface area. Percentage of burnt surface area. Clear? It is crystalloid based. So this is the amount of crystalloids required in 24 hours. Let's discuss. Imagine if the patient body weight is 50 kg and patient is having 50% burns. Body weight is 50 kg and patient developed 50% burns. How much is the total fluid requirement? So it is 4 into 50 kg into 50%. So total is 10,000 ml. It means for 24 hours, how much is the requirement of fluid? 10 liters. Imagine a patient who is having 60% of burns. 60%. Even if patient is having 70%, 80%, the maximum fluid given is calculated according to 50%. So the maximum value is calculated according to 50% of burns only. Otherwise, patient will develop fluid overload. So you have to remember, maximum fluid is given, it's calculated according to 50% of burn surface, right? So here in this example, the requirement is 10 liter. Half of this fluid is given in first 8 hours and rest half is given in next 16 hours. So half of fluid means 5 liters will be given in first 8 hours, right? And rest 5 liters will be given in next 16 hours. Simple. There was one question in DNB that what is the second day fluid requirement? And second day fluid requirement is 40 to 60% of first day fluid requirement. If we take average, it's 50%. So the second day fluid requirement, it means for the next 24 hours, this is for the first 24 hours. For next 24 hours, how much is the fluid requirement? It's average 50%. So 5 liters, right? So suppose the X amount of fluid is given in first 8 hours, that amount will be given in next 16 hours and the same amount will be given in next 24 hours. This is the Parkland formula. There is ATLS modification of Parkland formula on the basis of age of patient, body weight and nature of injury. So according to ATLS modification, in adults patient and in children who are more than equal to 14 years of age, how much is the fluid given? It is 2 ml into body weight in kg into percentage of burnt surface area. In classical Parkland, it is 4 ml. Okay. If the weight of child is less than equal to 30 kg or age is less than 14 years. Here, how much fluid? We give 3 ml. 3 ml into body weight in kg into percentage of burn surface area. And patients who are having electrical burns, irrespective of age, irrespective of body weight, how much? It is 4 ml into body weight in kg into burned surface area, percentage of burned surface area. So this is ATLS modification. It's easy to remember. It is 2, 3, 4. Adults and children more than equal to 14 years of age, 2 ml into body weight in kg into percentage of burned surface area. Children less than 14 years of age, body weight less than equal to 30 kg, it is 3 ml. And any patient who is having electrical burns, what? It's 4 ml into body weight in kg into percentage of burned surface area. So which one to apply in exam? In the exam, if it is mentioned ATLS modification, you apply this 2 ml formula, because in most of the cases adult patients are mentioned. If nothing is mentioned, we will apply classical Parkland, that is 4 ml per kg, right? So until and unless in the question it's mentioned ATLS modification, we are going to apply the classical Parkland, and that is 4 ml into body weight in kg into percentage of burned surface area. So how we are going to monitor the fluid resuscitation? What's the best clinical indicator for tissue perfusion in burn patients? And this is what? Urine output. Almost every year this question is asked. Best clinical indicator of tissue perfusion, it's the urine output. How much should be the minimum urine output after adequate tissue perfusion in adults and in children? In adults, it's 1 ml per minute in adults, and in children, it's 0.5 to 1 ml per minute. In children, 0.5 to 1 ml per minute. Sometimes they ask this value in per hour. So if it's 1 ml per minute, obviously in adults it's 60 ml per hour in adults, and in children obviously it is 30 to 60 ml per hour. Okay, remember this value, very important. In burn patients, to assess the estimate of injury, we have to assess the burn size, that how much body surface area is burnt. And in adults, the most commonly used formula is rule of 9, given by Alfred Russel Wallace. The third important formula is Palmer method or rule of Palm. What's the problem? Certain patients are having mixed distribution of burns, in which the burn is involving some part of face, some part of upper limb, some part of chest, abdomen. So here the calculation becomes difficult. So in this we use this Palmer method or rule of Palm. So what happens here? The area of open hand is included. So this is the area under palm and extended fingers, and this corresponds to how much? 1% of body surface area of the patient. So Palmer method, the area included under the open hand, it is 1% of body surface area. So what we do, we are going to put the hand on a piece of paper. We are going to cut that piece of paper according to the shape of hand. And with that piece of paper, we are going to measure that how much burned surface area is there. Clear? So this Palmer method or rule of Palm, it is used for splash burns because of hot liquids, and for mixed distribution of burns. Splash burns and for mixed distribution of burns. One of the important aspect of burns is cooling of the burn wound. So whenever there is burns, we should cool the burn wound for minimum of 10 minutes. So for how long? This cooling should be done for minimum of 10 minutes at least. And this cooling is effective up to 1 hour after burns, right? Effective up to 1 hour. What is the best temperature of water used for cooling? It's 15 degrees centigrade, or it's the tap water. Clear? So it's 15 degrees centigrade or the tap water. You should not use cold water or ice. Why? Because if you are using cold water or ice, first thing that it is going to increase the risk of hypothermia. And second, if the burn surface area is not very large, what happens? At the site of application, there is cutaneous vasoconstriction. And because of vasoconstriction, it is going to increase the thermal damage. So ice, cold water should not be used because it's going to increase the risk of hypothermia. And cutaneous vasoconstriction increases the risk of thermal damage. Best temperature is 15 degrees centigrade. In a state entrance exam, question was asked in burn patients, which is preferred, topical antimicrobials or systemic antimicrobials like oral or IV. So it's the topical antimicrobials which are preferred. These are preferred over systemic agents. Okay, why topical antimicrobial agents are preferred over systemic agents? Because in burn patient already what happens, there is fluid loss, patient is having hypovolemia, the systemic agent might increase the risk of renal failure. Okay, so topical antimicrobials having lesser side effects preferred over systemic agents. So what are the agents which are used? We use 1% silver sulfadiazine, 0.5% silver nitrate, there is 5% mefenide acetate, or we give combination of silver sulfadiazine and cerium nitrate. You know that this silver sulfadiazine, this is for antimicrobial prophylaxis against Pseudomonas. It's against Pseudomonas and MRSA. We discussed what's the most common organism responsible for sepsis in burn patients? Pseudomonas. So we use this 1% silver sulfadiazine for prophylaxis against Pseudomonas and MRSA. You know, skin grafting is one of the important aspect of burn wound management. So what are the instruments which are used for harvesting the skin graft? This is Humvee knife. Humvee knife. This image-based question was asked many times in AIMS, INI, CET, NEET, PG, FMG. Humvee knife. And here you can see this is electric dermatome. Okay. So either we can use Humvee knife or this electric dermatome. With the help of these instruments, we can calibrate the skin thickness which can be harvested. So for skin grafting, Humvee knife and electric dermatome are used. On the basis of the skin thickness removed, it is further divided into split thickness skin grafting and full thickness skin grafting. So see this image. If we are taking epidermis plus part of dermis, we are going to harvest epidermis plus part of dermis, that's split thickness skin grafting, and it is also known as Thiersch skin grafting. And when we include the whole thickness of dermis, epidermis plus full thickness of dermis is included in the graft, this is known as full thickness skin grafting. And what's the other name? It's also known as Wolff's skin grafting. This is very important. See the differences between split thickness skin grafting and full thickness skin grafting. So other name of this is the question which is asked. Split thickness skin grafting, Thiersch. Full thickness skin grafting is Wolff's. So in split thickness skin grafting, epidermis and part of dermis is taken, whereas in full thickness grafting we take full thickness of dermis. So apart from epidermis, we are taking full thickness of dermis, right? What is the good thing about split thickness skin grafting? That here the donor site heals spontaneously. In this case, we can take large graft. Another good thing that the graft survival is easy, right? What is the good thing about split thickness skin grafting? That the donor site heals spontaneously. Since the donor site is going to heal spontaneously, we can take large graft. We can take repeated grafts. And another good thing that here the graft survival is easy. What's the problem with full thickness skin grafting? In this you are taking epidermis plus full thickness of dermis. So at the donor site there is permanent defect, and this defect should be closed by suturing, or it can be left open by healing by secondary intention. It means there is permanent defect at the donor site. That's why we can take only small graft, and the graft cannot be taken repeatedly. So another difference here, we are going to take only small grafts. Graft survival is difficult and donor site develops permanent defect. There is permanent defect, and since permanent defect is there, that's why we cannot take repeated grafts. In split thickness skin grafting, what's the problem? There is significant graft contraction, and if there is significant graft contraction, what's the problem? There is poor cosmetic appearance. Poor cosmetic appearance. The good thing about full thickness skin grafting is that here there is lesser graft contraction. And if there is lesser graft contraction, what's the good thing? In comparison to split thickness skin grafting, here there is good cosmetic appearance. Clear? Good cosmetic appearance. These are the differences, and you must be knowing what is the most commonly used donor site for split thickness skin grafting. We take it from inner aspect of thigh. What's this donor site most commonly used? It's the inner aspect of thigh, right? These are important points related to skin grafting. Presence of one organism is an absolute contraindication for skin grafting. What's that organism? It's beta hemolytic streptococci. Presence of beta hemolytic streptococci. Yes, its presence is an absolute contraindication. Why? Because this organism is going to produce hyaluronidase, which is going to destroy the graft completely. So beta hemolytic streptococci presence is an absolute contraindication for skin grafting. Imagine a patient who is having musculoskeletal injury and there is exposed bone because of loss of the skin. If the bone is exposed, joint is exposed, you cannot use skin graft. Why? Because here the recipient bed is relatively avascular. So in these cases, we have to use the pedicled graft, means the graft which is having its own blood supply, and that's known as what? Flap. Flap is partially or completely isolated segment of tissue with its own blood supply. What's the other name? It's also known as pedicled graft. Okay, so what are the indications of this flap or pedicled graft? Exposed bone, exposed brain, radiated vessel. Radiated vessel means suppose patient is going to receive radiotherapy. After radiotherapy, there is obliterative endarteritis. So what happens? The recipient bed becomes relatively avascular or hypovascular, and it is not going to accept the graft. Pressure sore, especially at the bony prominences. What? We are going to apply the flap. And if there is open joint, or sometimes when we are using implant materials, when we are going for replacement, so at all these places we use flap. On the basis of vascular supply, there are three types of flap: random flap, axial flap, free flap. So these are the types of flap on the basis of vascular supply. First is random flap. It is based on a random vessel. What's that? Can you see this? Yes. So it is based on subdermal plexus of vessels. Random flap is based on a random vessel, that is subdermal plexus of vessels. Here you can see. Okay. And generally, what's the use of this random flap? It is used to reconstruct small full thickness defect. Small full thickness defect. Axial flap we discussed in breast. We discussed tram flap, transverse rectus abdominis muscle flap. We discussed LD flap. Whenever a flap is based on named vessel, example, we discussed that tram flap, transverse rectus abdominis muscle flap is based on inferior epigastric artery. LD flap is based on thoracodorsal vessels. So if it is based on named vessel, it's axial flap. Whenever a flap is devascularized from donor site, revascularized at recipient bed, it is free. And how we are going to perform the revascularization? With the help of microvascular anastomosis. So what is free flap? Devascularized from donor site, revascularized at recipient bed. So these are the three types based on vascular supply. Two important flaps which are frequently asked. Have a look. So in this patient, you can see that for the reconstruction of cheek here, means the defect in the head and neck region, what? The flap is based on this pectoralis major muscle, and this is PMMC flap. What is the full form? It is pectoralis major myocutaneous flap. This pectoralis major myocutaneous flap, it is based on pectoral branches. Can you see? It is based on pectoral branches of thoracoacromial artery. And this is the most commonly used flap for the reconstruction of head and neck defects. In India, you know that oral cavity is very common malignancy, especially in UP and Bihar. After excision of this head and neck malignancy, especially of the oral cavity, when we are going to perform the reconstruction, we are using pectoralis major myocutaneous flap. It is based on pectoral branches of thoracoacromial artery. This is one flap. There is another flap used for reconstruction of head and neck defects, and that is what? Deltoid region pectoral flap, DP flap. So see, this is deltoid, this is pectoralis. What's the name of this flap? This is deltopectoral flap, and this deltopectoral flap is based on internal mammary artery. Internal mammary artery. Clear? And this is also used for reconstruction of head and neck defects. So these are two commonly used flaps for reconstruction of head and neck defects. First, see what is the definition of ulcer. So ulcer is break in continuity of covering epithelium or mucous membrane. And why there is break in continuity? Because of molecular death or traumatic removal. Okay, so it's because of molecular death or traumatic removal. The most important question which is asked in viva as well as in exam is what are the parts of ulcer? So there are four parts. There is base, floor, edge, margin. How to imagine? It's very easy to imagine or remember. Imagine this is your room. Okay, this is your room. On the floor, you can see that there is either marble or tiles. Clear? Marble or tiles. And that marble or tiles is placed over a concrete thing. So there is concrete. On concrete, you place marble or tiles, and then there are walls, and then there is a ceiling or roof. Right? So the concrete is what? It's the base. Means it's the base on which the ulcer is going to rest. Floor, it's composed of, in the floor what you can see? Tiles or marble. So floor is exposed surface of ulcer, and in ulcer you can see what? Slough, granulation tissue. Then what's the edge? You see the walls. Walls are the edge. And what is the margin? Where the walls are going to touch the ceiling or roof, that's margin. So see the definition. What's the base? Is the surface on which ulcer rests. Surface on which ulcer rests. So generally it is muscle. In some patients it's bone. Floor. Floor is the exposed surface of ulcer. What? This is exposed surface. And what you can see in the floor, sometimes you can see discharge, there is slough, there is granulation tissue. You can see edge. Edge. So what is this edge? Edge is the area located between floor and margin. So this is located between, edge is located between floor and margin. This on which ulcer rests, generally it's muscle or bone. Floor is exposed surface of ulcer having slough or granulation tissue. Edge is the area between margin and the floor, and margin is the junction between normal epithelium and ulcer. Many questions are asked related to edges. On the basis of edges, how you can identify the kind of ulcer. So here you can see there is sloping edges, and these sloping edges are seen in venous ulcer. We discussed it's seen in venous ulcer. Okay, this kind of edge, this is what? It's punched out, and this punched out edges are seen in arterial ulcers. So this is seen in arterial ulcers. This is very important. Here you can see the edges are undermined. Focus on this part. Edges are undermined, and undermined edges are typically seen in tuberculosis. So it is seen in tubercular ulcer. Here it's the rolled edges or rolled out edges. Rolled out edges are seen in basal cell carcinoma. There is another important property of basal cell carcinoma, that in periphery you are going to notice what? Pearly white nodules, and there is central depression or umbilication. So rolled out edges in basal cell carcinoma, and this kind of everted edges are seen in squamous cell carcinoma. So everted edges are seen in squamous cell carcinoma. See this patient, in a burn scar, this patient developed a malignancy. So what's the name of that malignancy which develops in the burn scar or develops from chronic benign ulcer? It's the Marjolin's ulcer. So name, it's Marjolin's ulcer. Very, very important topic. It arises from, or it's going to develop in burn scar or chronic benign ulcer. Burn scar or chronic benign ulcer. Okay, what is the type of this Marjolin ulcer? Marjolin's ulcer is low grade squamous cell carcinoma arising from scar tissue. Now important properties. You know, in the scar tissue there is no vessels, no artery, no veins, lymphatics are destroyed, nerves are destroyed. So if these structures are destroyed, what are the characteristic features of Marjolin's ulcer? So first question, since there are no nerves or nerves are destroyed, it is painful or painless? Marjolin's ulcer, it's painless. Second, it is avascular. If it's avascular, this is slow growing or fast growing? Slow growing. It is radiosensitive or radioresistant. The vascular tumors are radiosensitive. So it is radioresistant because of avascular nature. The tumor is, it's slow growing, and this is radioresistant. Simple. Radio resistant. There is no lymphatics. So if lymphatics are also destroyed, obviously there is no lymph node metastasis. How we are going to make the diagnosis? Investigation of choice for diagnosis, it's biopsy. So we go for biopsy. And how we are going to treat it? We perform wide local excision with flap cover, because after wide local excision there is defect. So what's the treatment? We go for wide local excision plus flap cover. Okay, so we have to cover the exposed area with flap. What is the most common type of skin malignancy worldwide? And you know, it is basal cell carcinoma, followed by squamous cell carcinoma, followed by malignant melanoma. Most common type of skin malignancy. Twist in the question. Most common type of skin malignancy in darkly pigmented races. And in darkly pigmented races, the most common type of skin malignancy is squamous cell carcinoma. In darkly pigmented races. Clear? One by one we are going to discuss. First we are going to discuss basal cell carcinoma. You know, basal cell carcinoma is also known as rodent ulcer. Why? Because it's locally invasive. It is going to destroy the surrounding tissue. It is also known as tear cancer. Why? Because if you are going to join the ear lobule with the corner of mouth, basal cell carcinoma is generally located area above this line, joining ear lobule to the corner of mouth. Okay. Basal cell carcinoma, why it's known as basal cell? Because it arises from which layer of skin? Basal layer. Arises from which layer of skin? Basal layer. And what's the most common site? It's the nose, followed by inner canthus. The most common site, it's nose, followed by inner canthus. You have to remember. Right? Image based questions are asked related to basal cell carcinoma in FMG, in NEET, PG, INI, CET. See the image. In this image you can see there is presence of pearly white nodules in the periphery, and in the center you can notice that there is central depression or umbilication. This is the most common type of basal cell carcinoma. And what's that most common type? It's the nodular variety. This nodular variety is having pearly nodules in the periphery. There is central umbilication or depression. Another important thing, that there is telangiectatic vessels on the surface. So here you can notice dilated or telangiectatic vessels on surface. Clear? What is the most common type of basal cell carcinoma? It's the nodular variety. How we are going to make the diagnosis? So diagnosis of basal cell carcinoma, squamous cell carcinoma, malignant melanoma, in all these cases we have to perform what? Biopsy. So investigation of choice for diagnosis is biopsy. In all these cases we have to go for wide local excision. So here also the treatment is wide local excision with 2 centimeter margin. But imagine a situation where tumor appears aggressive, involving vital areas, cosmetic areas, or tumor is recurrent. Aggressive tumor, tumor involving vital areas, cosmetic areas, or recurrent tumors. In such cases, we go for Mohs micrographic surgery. This Mohs micrographic surgery is not only done for basal cell carcinoma, it is also done for squamous cell carcinoma. So squamous cell carcinoma, which is aggressive, which is involving cosmetic areas, vital areas, and which is recurrent, in that case also we go for Mohs micrographic surgery. So basal cell carcinoma, squamous cell carcinoma management is almost similar. We go for wide local excision with 2 centimeter margin. Second alternative is Mohs micrographic surgery. So this is squamous cell carcinoma. You know, squamous cell carcinoma is the second most common skin malignancy and most common skin malignancy seen in darkly pigmented races. Here you can see the presentation. The most common presentation of squamous cell carcinoma is what? Ulcer. And what kind of edges are there? There is everted edges. In ulcers there is everted edge. Clear? And in these patients there is indurated base. These are the special features of ulcer. Indurated base, everted edges. What is the most common risk factor for squamous cell carcinoma? It's the sunlight. It means the exposed surface of the body is most commonly involved. So which part of body is exposed to sunlight? You can see what? Ears, cheeks, lower lip, and what? Dorsum or back surface of hand. These are the areas which are involved. So here the most common risk factor is sunlight, and that's why it's the exposed part of body which is most commonly involved. The questions related to pathology. So we discussed most common type is ulcerative variety, and on histopathological examination what you are going to find, there is cell nest or epithelial pearl or keratin pearl. So there is cell nest, epithelial pearl, or we find keratin pearl. These are the questions related to pathology, right? Management is similar to basal cell carcinoma. Investigation is similar. Investigation of choice for diagnosis is biopsy. Treatment of choice, wide local excision with 2 centimeter margin. If it's aggressive, involving vital areas, cosmetic areas, or tumor is recurrent, we go for what? Mohs micrographic surgery. This is malignant melanoma. And you know, malignant melanoma is caused by malignant transformation of which melanocytes? Junctional melanocytes. Which one? Is the junctional melanocytes. Malignant transformation of junctional melanocytes. So what's the location of this junctional melanocytes? These are located at dermoepidermal junction. Dermoepidermal junction. Now what is the most common site of malignant melanoma? If we see, in males it's the back and trunk, and in females it's the lower extremity. So most common site, males it's back and trunk, and in females it's the lower extremity. Okay, if you remember in NEET PG there was one question related to markers. So which markers are positive in malignant melanoma? You have to remember S100, HMB45 and Vimentin. These are positive. Clear? Which one is negative? Cytokeratin 20. This was there in the option. So cytokeratin 20 is negative, S100, HMB45, Vimentin, it is positive. You must be knowing that we discussed HMB45 is also positive. In which renal tumor? Angiomyolipoma. See the types of melanoma according to decrease in the incidence. So question, what is the most common type of malignant melanoma? Obviously, is the superficial spreading. What is the least common type of malignant melanoma? It's acral lentiginous. Which one is most malignant? It's nodular. And which one is least malignant? It's lentigomalina. Least malignant, lentigomalina. Right? Now see the locations. What is the most common location of or most common site of superficial spreading? So it is torso or the trunk. The most common site is torso or the trunk. Second is nodular. Why it's most malignant? Because it's having only vertical growth phase. Only vertical growth phase is there. And in this case, what's the most common site? It's head and neck. Lentigomalina, it is least malignant, generally seen in elderly. And what's the most common site? It is face. Acral lentiginous, this is least common, but it's having worst prognosis. Worst prognosis. And what's the most common site of acral lentiginous? It's the sole. Where exactly in the sole? Under the great toenail. The most common site is sole. Where exactly? Under the great toenail. What are the characteristic features of malignant melanoma? So you can easily remember it by A, B, C, D, E. So what happens? There is asymmetry, there is border irregularity, color variation, change in diameter, how much? More than 6 mm, and there is evolution in what? Size, shape or color. So here you can see a normal mole. It's symmetrical. You can see the borders are even. There is a single color, diameter less than 6 mm. So this is ordinary mole. And here you can see melanoma. Asymmetrical. Can you see? Uneven borders, multiple colors, diameter more than 6 mm. And you can see the change in size, shape or color. So asymmetry, border irregularity, color variation, change in diameter, diameter more than 6 mm. Evolution in size, shape, color or pattern. This is A, B, C, D, E of melanoma. What is the most common route of spread in melanoma? It's lymphatic. There is lymphatic spread. And what's the most common site of metastasis in malignant melanoma? It's the liver. Now imagine if there is a small lesion, we can go for full thickness excisional biopsy. And if there is a large lesion, in these cases, we go for what? Incisional biopsy. For small lesion, full thickness excisional biopsy. Larger lesion, we go for incisional biopsy. Just like squamous cell carcinoma and basal cell carcinoma, here also, we go for wide local excision, and the margin depends on the depth of penetration. Usually, on an average, here also, we take 2 centimeter margin. Usually, but exact margin is dependent on the depth of penetration. On the basis of depth of invasion of malignant melanoma, there are 5 Clark levels. So what's type 1? In type 1, there is invasion of epidermis. In type 2, invasion of papillary dermis. In type 3, invasion of interface or junction of papillary and reticular dermis. In type 4, there is invasion of reticular dermis, and in type 5, there is invasion of subcutaneous fat. So these are 5 types. How to remember? Easiest way to remember is this mnemonic word, appears. It's appears. So 1, invasion of epidermis, 2 papillary dermis, 3 interface, 4 reticular dermis, and 5 subcutaneous fat. There is Breslow staging, which is preferred over Clark levels, and it is based on actual measurement of deepest invasion from granular layer. What's the name? Breslow staging. So Breslow staging, it is based on actual measurement of deepest invasion from which layer? Granular layer. In stage 1, when the depth of invasion is less than 0.75 mm. If it is 0.75 mm to 1.5 mm, it is included in stage 2. In stage 3, it is 1.6 to 4 mm. How much? 1.6 to 4 mm. And in stage 4, it's more than 4 mm. It is based on depth of invasion. So one common question, what is the most important prognostic factor in malignant melanoma? And the most important prognostic factor in malignant melanoma, obviously what? It's the depth of invasion. Depth of invasion is the most important prognostic factor, right? These are the important points related to malignant melanoma. See these images, these are sebaceous cysts. What are the other names of sebaceous cyst? It is also known as epidermal cyst, or epidermoid cyst. Why it is known as epidermal cyst? Because it is caused by proliferation of epidermal cells. Okay. If we see the sebaceous cyst, you can notice that there is punctum, black colored punctum, but there are two exceptions. In the scalp and in the scrotum, you can see there are no punctum. So punctum is not present in the sebaceous cyst of scalp and scrotum. What's the treatment of choice? We are going to excise the cyst. Whenever we are going to do the excision, we have to remove the wall also. So excision of cyst along with its wall should be removed to prevent recurrence, and that's the treatment of choice. Here you can see a swelling over the outer angle of eye in close proximity to eyebrow. This is known as angular dermoid. Nowadays this is a favorite question of examiners, image based question. Angular dermoid. So what's the location? Outer angle of eye in close proximity to eyebrow. Generally it is in relation to which suture? Here there is frontozygomatic suture. So it is in relation to frontozygomatic suture. What kind of swelling is this? This is painless, soft, smooth swelling. What kind of? Painless, soft, smooth swelling. And what's the treatment of angular dermoid? We go for excision. So this is angular dermoid. Now see the important vascular anomalies related to skin. This is looking like strawberry. Can you see? It looks like strawberry. That's the name, strawberry angioma. This strawberry angioma is a type of capillary hemangioma. In these cases, the child is normal at birth. This child is normal at birth. So generally this strawberry angioma is going to appear at 1 to 3 weeks. It grows along with child till 1 year. And what's the good thing? In 90% cases, what? There is spontaneous resolution by 9 years of age. Spontaneous resolution in 90% patients by 9 years of age. Okay. Whenever we are going to press this strawberry angioma, after applying the pressure, if you remove the pressure, there is emptying sign. So in strawberry angioma, emptying sign is positive. Second is Salmon's patch. First thing, that this is present at birth. It's present at birth. This patch is there at birth. See the location. Here it's located in forehead. Generally the location is in the midline, either over forehead or over the occiput. Here, what's the good thing? That it disappears by 1 year. So there is spontaneous regression by 1 year of age. There are various other names. Salmon's patch is also known as macular stain, also known as stork bite. Also known as stork bite or macular stain. Okay. The third is port wine stain. If you see the location is in the face, especially involving the areas which are supplied by fifth cranial nerve, trigeminal nerve or fifth cranial nerve. Here also, this anomaly is present at birth. Okay, so it's present at birth. Generally, it grows along with child and it doesn't regress. Out of these three, only this one doesn't regress. Okay, so two questions which are frequently asked: which of the anomalies are present at birth? Salmon's patch, port wine stain, these are present at birth. Which two are going to regress? Strawberry angioma, Salmon's patch is going to regress, and which one is going to persist? It's the port wine stain. See, the one-liner questions related to plastic surgery which are asked almost every year. This is infected sebaceous cyst of scalp, and it is also known as what? Cox peculiar tumor. What's the name? It's Cox peculiar tumor. This is infected sebaceous cyst of scalp. Here you can see there is osteomyelitis of skull bone. Which bone? You can notice here, it's the frontal bone. Okay, so osteomyelitis of skull bone, this is known as Pott's puffy tumor. Frequently asked question, this is Pott's puffy tumor. Is the osteomyelitis of skull bones, and the most commonly involved bone is what? Frontal bone. Here you can see this is pilomatrixoma. And what is the other name of this pilomatrixoma? It is also known as calcifying epithelioma of Malherbe. What's the name? This is pilomatrixoma. It is also known as calcifying epithelioma. Calcifying epithelioma of Malherbe. Okay, it's a benign hair follicle derived tumor, pilomatrixoma. In this image, you can see that there is piling of tissue one over another. This is looking like a turban, so it's also known as turban tumor. Turban tumor. And what's the other name? Cylindroma. Cylindroma. So cylindroma is also known as turban tumor. Why? Because there is piling of tissue one over another. So these are important one-liner questions, and this is all about burns and plastic surgery. Now we are going to discuss wound healing, tissue repair and scar. What is the definition of wound? It is breach in continuity of skin or surface epithelium. What? Breach in the continuity of skin or surface epithelium. First, we are going to discuss the classification of surgical wounds. And you know, surgical wounds are divided into four classes. What is class 1? Clean wound. Class 2, clean contaminated wound. Class 3, contaminated wound. And class 4, dirty wound. Have a look. So in classification of surgical wound, class 1 is known as clean wound. And in this particular class, respiratory tract, gastrointestinal tract and genitourinary tract is not entered. Genitourinary tract, this is not entered. This is clean wound. Okay, so it is uninfected operative wounds when there is no inflammation. Respiratory tract, gastrointestinal tract, genitourinary tract, these are not entered. And how we are going to close these kind of wounds? These are closed primarily. What are the classical examples you have seen in OT, which is done on daily basis? Hernia surgery. You have seen thyroidectomy. You have seen mastectomy. Whenever we are going for joint replacement, and whenever we are performing abdominal aortic aneurysm repair. So these are the examples, right? So inguinal hernia operation, mastectomy, thyroidectomy, joint replacement, abdominal aortic aneurysm, all these are examples of clean wound. In class 2, which is also known as clean contaminated wound, here what's the difference? That respiratory tract, GIT, gastrointestinal tract and genitourinary tract is entered, but it is entered under controlled condition and there is no unusual contamination. So without unusual contamination, this is class 2, that's clean contaminated wound. The clean contaminated wound includes cholecystectomy, CBD exploration in which we enter the CBD, elective GI surgery like elective colonic resection, elective colonic resection. So here what you are going to notice that we are going to enter the GIT, but what bowel preparation is there, so there is no unusual contamination. Similarly, elective gastrectomy, elective gastrectomy. So cholecystectomy, CBD exploration, elective GI surgeries, all these are examples of clean contaminated wound. What kind of questions are asked in exam? They will give you the examples and then they will ask you the class. That's why you are supposed to remember the classical examples also. Class 3 is contaminated wound. It means in these wounds contamination occurs. And what's the cause of contamination? It's either because of accidents, or sometimes there is major break in sterile technique during surgery. So if there is major break in sterile technique during surgery, right? So what are the wounds which are included? In this case, you are going to notice that there is open, fresh, accidental wounds. And in these accidental wounds, what's the problem? There is contamination. Second thing, if we are performing the surgery and there is major break in sterile technique, or sometimes there is gross spillage from GIT. If there is gross spillage from GIT. So generally in contaminated wound, acute non-purulent inflammation is encountered. Means pus collection is not there. Already pus or organism is not present in the wound. If frank pus is already present, if there is presence of devitalized tissue, there is infection or organism causing infection is already present in the wound, that's dirty and it's included in class 4. So class 3 is contaminated wound. See the examples. So these contaminated wounds include appendicular perforation, gastric perforation whenever we are performing enterotomy during intestinal obstruction or bowel obstruction, if there is human bite or some open fracture is there because of accident. So these are contaminated wounds. Class 4 is dirty wound. What you have to remember here, that infection or organism causing post-operative infection is already present in the wound. So infection or organism causing infection, it's already present in the wound, already present. It means what? This is old traumatic wound in which there is retained devitalized tissue. Okay, or these patients are having wound in which there is clinical infection, or these patients have perforated viscera with high degree of contamination. An important point here, purulent inflammation is there. In class 3 we saw non-purulent inflammation is encountered during incision. Here there is purulent inflammation, so there is severe purulent inflammation in class 4. That's why it's known as what? Dirty wound. Here perforated diverticulitis. If there is fecal peritonitis, already fecal matter is there in the peritoneal cavity, there is presence of frank pus or necrotizing soft tissue infection is there. All these are included in dirty wound. Another question which is asked related to surgical classification of wound, that how much is the risk of infection in particular classes and in which particular class antibiotic prophylaxis is required. Okay, first see the risk of infection. If we see clean wound, the risk of infection is 5%. Clean contaminated wound, it's 10%. Contaminated wound, it's 20 to 30%. And in dirty wound, how much? It's 30 to 40%. How to remember? Yes, 5, 10, 20, 40. This is class 1, this is class 2, this is class 3, this is class 4. So class 1, that's clean 5%, clean contaminated 10, contaminated 20, and dirty wound how much? 40%. Now see in which cases antibiotic prophylaxis is not required. So you must be knowing that in clean wound antibiotic prophylaxis, it's not required. Not required. In clean contaminated wound, it's usually required. And always required in contaminated wound. So usually required in class 2, that's clean contaminated wound, and always required in contaminated wound, right? See the situation. Wound is already dirty. There is dirty wound. There is presence of organism or infection is already present. Here, we are not going for prophylaxis. We have to start the treatment. So, in this case, treatment is required. Here, treatment is required, not the prophylaxis. One of the best way to prevent surgical site infection or wound infection is frequent hand washing. So whenever we are going to attend the patients, after attending one patient, we should wash the hand. So hand washing decreases the risk of surgical site infection. Sometimes definitions are asked, like what's the definition of chronic wound? So any wound that does not heal within 3 months. If the wound is not going to heal within 3 months, you have to remember, within 3 months. And delay in healing can occur in any phase of wound healing, but mainly the delay is in inflammatory phase. So generally in patients of chronic wound, where is the delay? Generally the delay occurs in inflammatory phase. Okay, you have seen patients of paraplegia, patient of quadriparesis in the ward. Yes, these patients are going to develop what? A wound which is chronic. It's not going to heal within 3 months. What's the example? Yes, you have seen bed sore or pressure sore, right? So classical example is bed sore or pressure sore. Clear? For the chronic wound, it doesn't heal within 3 months. See this image and tell me what kind of injury is this? This is degloving injury or avulsion injury. What's the name? This is degloving injury, also known as avulsion injury. Okay, see what happens in degloving injury or avulsion injury. Here you can see this is the skin and subcutaneous fat. So in degloving injury or avulsion injury, skin and subcutaneous fat is stripped off from the underlying fascia. So when skin and subcutaneous tissue is avulsed or it's stripped off from underlying fascia, leading to exposed neuromuscular structures. So here you can see exposed neuromuscular structures. Here you can see exposed bone and you can see exposed tendons. Clear? So skin subcutaneous fat is stripped off, leading to exposed neuromuscular structures, bone and tendon. This is known as degloving injury, also known as avulsion injury, and this definition was asked in NEET PG. Another important topic which is frequently asked both in surgery and ortho, that's compartment syndrome. You know, in compartment syndrome, the pressure in the affected compartment, it's more than 30 mmHg. And generally, it is seen in which kind of injury? Closed lower limb injuries. What? Closed lower limb injuries. Okay. Now see the clinical features. This patient is having complaint of severe pain out of proportion of apparent injury. Severe pain out of proportion of apparent injury. And whenever we are going for passive stretching of the muscle of the affected compartment, there is pain. So pain on passive movement. What is the other problem? There are distal sensory disturbances. Absence of distal pulses. It's a late sign. And in FMG, in NEET PG, in INI-CET, in all these exams, compartment syndrome was asked, and question was asked, pulselessness and paralysis. Out of pulselessness and paralysis, which one is associated with worse prognosis? It's the paralysis. Paralysis is associated with worst prognosis in compartment syndrome. Okay. In compartment syndrome, how we are going to make the diagnosis? We are going to measure the pressure in the compartment and it's more than 30 mmHg. How we are going to treat it? In compartment syndrome, you have to release the pressure. So what you have to perform? Fasciotomy. In all cases, we are not going to perform the fasciotomy. So what are the indications of performing fasciotomy? First, whenever the pressure in the compartment is more than 30 mmHg. And second, if patient is having signs and symptoms of compartment syndrome. Pressure more than 30, patient is having signs and symptoms of compartment syndrome. In this image, you can see that in fasciotomy, the longitudinal incision is given both on the medial side as well as on the lateral side. And in fasciotomy, the structures which are incised are skin, subcutaneous fat, and fascia. So structures which are incised are skin, subcutaneous fat, and fascia. Okay, whenever we are performing this fasciotomy, you will notice that the muscle is going to bulge through the fascia. This is fasciotomy performed for the patients of compartment syndrome, in which longitudinal incision is given both on the medial side as well as on the lateral side. Another hot topic which is frequently asked nowadays is the pressure ulcer. What are the other names? Also known as pressure sore, also known as bed sore. So term is self-explanatory. In pressure ulcer, there is ulcer because of prolonged pressure. What's the problem? There is ulcer because of prolonged pressure. That's why it's known as pressure ulcer. Because of this prolonged pressure, what is the problem? These patients are immobilized in one particular posture. Because of this prolonged pressure, it leads to tissue necrosis and ulceration. Clear? So there is tissue necrosis and ulceration. Okay. What is the question which is asked in exams nowadays? Staging of pressure ulcer or pressure sore. It's very easy to remember. See, if there is non-blanchable erythema of skin without any breach in the skin, that is stage 1. If there is partial thickness skin loss with involvements of epidermis and dermis, that is stage 2. If there is full thickness skin loss with involvement of subcutaneous tissue, means epidermis, dermis, subcutaneous tissue, all these are involved, this is stage 3. And whenever there is full thickness skin loss with involvement of subcutaneous fat, muscle and bone, this is stage 4. These are the 4 stages. Easiest way to remember, stage 1 is it's early superficial ulcer. Stage 2, this is late superficial ulcer. Stage 3, this is early deep ulcer. And what's the stage 4? Obviously it's the late deep ulcer. Easy to remember? See the images of these 4 stages. So here you can notice there is non-blanchable erythema of skin without any breach in the epidermis. So if there is no breach in epidermis, there is only non-blanchable erythema, that is stage 1. In stage 2, you can see there is partial thickness skin loss, including epidermis and dermis. So there is partial thickness skin loss including epidermis and dermis. This is what stage 2. We discussed stage 1 is early superficial ulcer, stage 2 is late superficial ulcer. In this picture you can see the bone is exposed, muscle is exposed, and here there is full thickness skin loss involving subcutaneous tissue. So if there is full thickness skin loss involving subcutaneous tissue with muscle and bone, that is stage 4, and it is late deep ulcer. In the wards you have seen the patients who developed bed sores, we are using special mattress. What? Water mattress, or we use special pressure dispersion foams or cushions, right? Simultaneously some advices are being given to the patient and relative. So if a patient is bed bound, patient should be turned every 2 hourly. So if patient is bed bound, relatives are explained to turn the patient every 2 hourly. So every 2 hourly we have to turn the patient. Second, if the patient is wheelchair bound, we have to tell the patient that you have to lift off yourself for 10 seconds every 10 minutes. So how much duration? Patient should lift himself or herself for 10 seconds every 10 minutes. You have to remember these durations because these are asked. So bed-bound patient should be turned every 2 hourly. If patient is wheelchair-bound, patient should lift himself or herself every 10 minutes for 10 seconds. Another question. Generally, these chronic wounds are not going to heal easily. So we have to use a flap. And what is the most commonly used flap for pressure ulcer or pressure sore? It is the extensor fascia lata flap with lateral cutaneous nerve of thigh. Most commonly used flap for pressure sore or pressure ulcer, extensor fascia lata flap with lateral cutaneous nerve of thigh. See this image. Here, vacuum is being applied over the wound or negative pressure is being applied. What's the name? This is known as vacuum assisted closure, also known as negative pressure wound therapy. So what's the name of this technique? This is vacuum assisted closure, also known as negative pressure wound therapy. So the term is self-explanatory. We are applying negative pressure to the wound. Question: how much negative pressure is being applied here? We apply minus 125 mmHg. Negative pressure applied, that's minus 125 mmHg, and this is applied 2 to 3 times in a week. So how much minus 125 mmHg? 2 to 3 times every week. Every week. What is the advantage of this negative pressure wound therapy? Since negative pressure is being applied, it is going to suck the excessive fluid collected, and second, it promotes the vascular supply. So it sucks out the excessive fluid, promotes the vascular supply, so it's going to hasten or it is going to improve the wound healing. So what are the primary effects of negative pressure wound therapy? It leads to macro deformation. So what happens? Suppose these are the wound edges. If you apply negative pressure, it brings the wound edges together. So it helps in approximation of the wound, which is going to improve the wound healing. Second is stabilization of wound environment. So it is going to protect the wound from outside microorganism. It is going to provide moist and warm environment. It reduces edema because it is going to suck the excessive fluid, and there is micro deformation. It helps in the cellular proliferation on the wound surface, right? So these are the primary effects. But there are contraindications also. In all wounds, we cannot use this negative pressure wound therapy. So what are the contraindications? The mnemonic is MUNNA. It's MUNNA. So M means if there is malignancy in the wound. U means if there is untreated osteomyelitis. N, non-enteric and undrained fistula. N, if there is necrotic tissue with eschar. So these are the contraindications of negative pressure wound therapy. What you have to remember: minus 125 mmHg applied 2 to 3 times every week in vacuum assisted closure or negative pressure wound therapy. You know, after wound healing, there is formation of scar. Okay. And what's the maximum tensile strength of scar? So how much is the tensile strength achieved by the scar? It is up to 80% of uninjured skin. So maximum is 80% of uninjured skin. This is the maximum strength. Second question: after how many weeks or how many months this 80% strength is achieved? So generally it is achieved after 3 months or 12 weeks of injury. Clear? So scar is going to achieve maximum strength of 80% of uninjured skin, and generally it is achieved after 3 months or 12 weeks of injury. There are 3 types of scar, you know. One is atrophic scar, second is hypertrophic scar, and third is keloid. Hypertrophic scar, keloid, these two are frequently asked questions. Let's compare both of these. In these two images, you can see that there is presence of excessive scar tissue. Here also you can see presence of excessive scar tissue. In the first image, this excessive scar tissue is not going to cross the boundary of original wound or incision. But in the second, the scar is going to extend beyond the boundary of original wound or incision. So first is hypertrophic scar, where the scar is not going to extend beyond the original wound or incision. And in the second, which is also known as keloid, here the scar is going to extend beyond the boundary of original wound or incision. So let's see the differences. So what are the differences between hypertrophic scar and keloid? Have a look. First, in both hypertrophic scar and keloid, there is presence of excessive scar tissue. In hypertrophic scar, this excessive scar tissue doesn't extend beyond the boundary of original wound or incision. Here, it extends beyond extends beyond the boundary of original wound or incision. Okay. What is the problem in hypertrophic scar? That there is prolonged inflammatory phase. In keloid, etiology is unknown. Keloid etiology is unknown, and you are going to notice that this keloid is seen in darkly pigmented races. So dark pigmentation increases the risk. In keloid, there are certain areas where it's more common. What's the most common site of keloid? It's the sternum. Sternum, overall, it's the most common site. And if we see, this keloid is generally seen in the triangular region. So what's the triangular region? Here you can see these are the shoulder tips and this is the xiphisternum. You join these three dots. So it's the triangular region between these shoulder tips and xiphisternum where it's more common. So the most common site is sternum. It is also seen in supraclavicular region, also seen in upper extremities, also seen in face, especially which region? Ear. In ear, which part? Ear lobule. So these are the common sites. Most common site, sternum. Other sites, face. In the face, ear lobule, upper extremities, and what? Supraclavicular region. It is also seen in the supraclavicular region. Okay. Now see the differences in the histology. In both hypertrophic scar and keloid, there is excessive collagen, there is hypervascularity. In hypertrophic scar, there is well organized type 3 collagen, but in keloid, it is disorganized type 1 and type 3 collagen. It's disorganized type 1 and type 3 collagen. What is the good thing about hypertrophic scar? That it is going to improve spontaneously, but keloid doesn't regress with time, and generally it is refractory to medical and surgical treatment. So keloid rarely regresses with time. Okay, and it is refractory to medical and surgical treatment. By the way, we have to try the treatment options for both hypertrophic scar and keloid. In hypertrophic scar, if there is ongoing hypertrophy, we have to inject the triamcinolone where in the lesion. So if there is ongoing hypertrophy, we perform intralesional injection of triamcinolone. Okay, it's a steroid. And if the scar is going to persist for more than 1 year, in that case we have to perform the excision of hypertrophic scar and we have to perform the primary closure. So if it persists beyond 1 year, we perform the surgical excision and then we go for primary closure in hypertrophic scar. So what's the first line treatment for keloid? Okay, in such patients we use pressure therapy. Yes, we use silicone, and we discussed we inject triamcinolone, so that's intralesional injection of triamcinolone. Okay, this is the first line treatment. Imagine if the keloid is refractory to this treatment. In that case, we go for surgical excision and we give post-operative radiotherapy. So for refractory lesions, we go for surgical excision and we go for post-operative radiotherapy. But we discussed that generally keloid is refractory to medical and surgical treatment. So these are the differences between hypertrophic scar, keloid, which is frequently asked question nowadays, especially in the form of image. So this is all about wound healing, tissue repair and scar. Now we are going to discuss important topics of neurosurgery. First, we are going to discuss neural tube defects. Neural tube defects are further divided into two types. One is spina bifida occulta. Occulta means hidden. So it is also known as closed spina bifida. Here you can see it is closed spina bifida. And the second is spina bifida aperta. In that we are going to include meningocele, myelomeningocele and myeloschisis. What are the special properties of these? Have a look. Now see the important features of various types of neural tube defects. First see spina bifida occulta. In this case you can notice that there is defect in the vertebra without any herniation of meninges or spinal cord. There is no herniation of meninges and spinal cord. There is some evidence on the skin. What you can notice that there is presence of tuft of hair, sometimes dimpling at the site of spina bifida occulta. What? Sometimes dimpling or presence of this tuft of hair. There is no herniation of spinal cord or meninges. See the second one. Second is meningocele. In meningocele, there is herniation of only meninges. And second is myelomeningocele. In myelomeningocele, apart from herniation of meninges, here you can see that there is herniation of spinal cord also. So in meningocele, only herniation of meninges, and in meningomyelocele, there is herniation of meninges with spinal cord. So in this meningocele, you can see that there is vertebral defects. Why are these vertebral defects? There is herniation of what? Only meninges. Okay, and here you can see that there is presence of clear CSF. So in the cystic sac, there is presence of clear CSF. If there is clear CSF in the cystic space and we are going to perform the transillumination test, what? This swelling is brilliantly transilluminant. So in this image, you can see it is brilliantly transilluminant. Cystic hygroma is brilliantly translucent, but meningocele is brilliantly transilluminant. Okay. Third important property, there is no herniation of spinal cord. The spinal cord location is normal and its development is normal. So there is normal location and there is normal development. Normal location, normal development. This question was asked many times in AIIMS, that in which cases immediate surgery is required. In majority of cases, immediate surgery is not required. So in which cases? When there is very thin skin, it is covered by thin skin, and sometimes there is leaking CSF. Okay, so if there is leaking CSF or it is covered by very thin skin, in these cases we go for immediate surgery. Otherwise, delayed surgery is performed for the patients of meningocele. This is myelomeningocele, and you know, myelomeningocele is the most severe form of dysraphism involving vertebral column. Okay, how much is the incidence? It's 1 in 4,000 live births, and you can see what's the most common site. Yes, is the lumbosacral region. So it is the lumbosacral region which is the most common site. We discussed that in myelomeningocele there is herniation of meninges and spinal cord. Herniation of meninges and spinal cord. We have read this in pharma and medicine that maternal use of anti-epileptics are going to increase the risk of neural tube defects, especially which type of neural tube defect? It's the myelomeningocele. So how to decrease the risk of neural tube defects? Yes, in periconceptional period, especially the females who are of childbearing age or the females who are about to become pregnant, in those females we give folic acid supplementation. And what's the dose? It's 0.4 mg per day. Folic acid supplementation, periconceptional supplementation, and how much is the 4 mg per day to decrease the or to prevent the neural tube defects. What are the causes of cerebrovascular accidents? Okay, the causes of cerebrovascular accidents are divided into ischemic causes and hemorrhagic causes. For 85% of cases, ischemic causes are responsible, and for 15% of cases, hemorrhagic causes are responsible. Okay, so most common causes ischemic. First question, in ischemic causes there are two things: either it's because of embolic occlusion or it's because of thrombotic cause. For 75% of ischemic causes, is the embolic occlusion which is responsible, and for 25% cases, it's the thrombotic cause. Okay, now see hemorrhagic causes. Out of 15%, the parenchymal hemorrhage is responsible for 10% of the cases. Subarachnoid hemorrhage is responsible for 1 to 2% cases, and both EDH and STH are responsible for less than 1% cases each. So now we are going to discuss the parenchymal hemorrhage, and this parenchymal hemorrhage is also known as what? Intracerebral hemorrhage. Okay, so what is the other name of parenchymal hemorrhage? It's intracerebral hemorrhage. Is the most common type of intracranial hemorrhage. What is the cause? The most common cause is hypertension. Because of this hypertension, there is rupture of small perforating arteries and arterioles. What? Rupture of small perforating arteries and arterioles. What is the most common site of parenchymal or intracerebral hemorrhage? Commonly asked question, and you know it's basal ganglia. Which part in basal ganglia? In basal ganglia, the most common site is what? Putamen. It's the putamen which is most common site of intracerebral hemorrhage. So intracerebral hemorrhage is the most common type of intracranial hemorrhage. What is the second most common type of intracranial hemorrhage? It's the subarachnoid hemorrhage. And this subarachnoid hemorrhage is the second most common type of intracranial hemorrhage. You know what's the most common cause of subarachnoid hemorrhage? It's the trauma followed by rupture of which aneurysm? Berry aneurysm. Trauma followed by rupture of berry aneurysm. Right? Berry aneurysm is very, very important. What is the most common intracranial aneurysm? It's the berry aneurysm. It is going to involve circle of Willis, especially which circulation? Anterior circulation. And you know what is the most common extracranial aneurysm? That is involving infrarenal aorta. So two question: most common site of intracranial aneurysm, circle of Willis. Most common type of intracranial aneurysm, berry aneurysm. Most common site of extracranial aneurysm, infrarenal aorta. So how this berry aneurysm appear? It is saccular. The appearance is saccular, and if you see, 85% of berry aneurysm is located in the anterior circulation. Especially it's going to arise from bifurcation of intracranial arteries. Okay, see the most common site. Here you can see that this is anterior communicating artery. This is anterior communicating artery, and this is anterior cerebral artery. So what is the most common site of berry aneurysm? Is the junction of anterior communicating artery and anterior cerebral artery. So this is junction of anterior communicating artery, anterior cerebral artery. This is the most common site. See the second most common site. This is middle cerebral artery, and this part is bifurcation of middle cerebral artery. So the second most common site is middle cerebral artery bifurcation. This is second most common site. What is the third most common site? You can see this is posterior communicating artery. Posterior communicating artery. And what is this? This is internal carotid artery. So third most common site is this. What? The junction of posterior communicating artery and internal carotid artery. So this is third most common site. Very, very important topic, asked in medicine, asked in pathology, asked in surgery. Most common site is the junction of anterior communicating artery and anterior cerebral artery. Second most common site, bifurcation of middle cerebral artery. And the third most common site is junction of posterior communicating artery and internal carotid artery. Now, what is the risk factor for Berry aneurysm? One of the most important risk factors is what? Smoking. See the important questions related to pathology because these were asked many times in AIIMS. Many times. First, what is the structural abnormality in Berry aneurysm? So, if you see, there is absence of smooth muscle as well as there is absence of intimal elastic lamina. Absence of smooth muscle and absence of intimal elastic lamina. So what is there in the wall? Wall is composed of thickened and hyalinized intima. Right? You have to remember absence of smooth muscle and intimal elastic lamina. So the wall of Berry aneurysm is composed of thickened hyalinized intima. There are two kinds of presentations. One, if the aneurysm is unruptured, majority of patients are asymptomatic. And if it is going to rupture, rupture can lead to intracranial hemorrhage or subarachnoid hemorrhage, and in some cases it can lead to both. So see the types. If it's unruptured, generally it's asymptomatic. Unruptured, asymptomatic. And if it's ruptured aneurysm, it can lead to intracranial hemorrhage or subarachnoid hemorrhage, or it can lead to both. Okay. Now see, where is the rupture? If this is the aneurysm, the rupture occurs at dome or at the apex. The most common site of rupture is the dome or apex. We discussed unruptured aneurysm, it's completely asymptomatic. Clear? So this is asymptomatic. How we are going to manage Berry aneurysm? We have two options. One is endovascular coil occlusion, and the second option is what? Surgical clipping of aneurysm. And even this question was asked in AIIMS, that which one is preferred. Is the endovascular coil occlusion is preferred over surgical clipping for the patients of Berry aneurysm. There are two important topics which are frequently asked in exam. One is Kernohan's notch phenomena and the second is Kernohan-Voltman sign. One by one we are going to discuss. First, see what is Kernohan's notch. Okay, so here you can see is the free edge of tentorium cerebelli. You can see here is the free edge of tentorium cerebelli, and this free edge is known as Kernohan's notch. This Kernohan's notch phenomena, it is seen in uncal herniation, also known as transtentorial herniation, uncal herniation or transtentorial herniation. So you can see what? There is uncal or transtentorial herniation. Because of this uncal or transtentorial herniation, what happens? There is indentation of contralateral cerebral peduncle. So what happens? Cerebral peduncle indentation against the free edge of tentorium cerebelli. I'm repeating. In uncal herniation or transtentorial herniation, there is contralateral cerebral peduncle indentation against the free edge of tentorium cerebelli, and because of this indentation there is ipsilateral third nerve palsy and ipsilateral hemiparesis. Okay, how to remember? Very, very easy. Mnemonic is there. Mnemonic is CPI third Hind precedent. Mnemonic is CPI third Hind precedent. So what is the problem? In Kernohan's notch phenomena, Kernohan's notch phenomena is characterized by this mnemonic CPI third Hind precedent. So in this case, there is cerebral peduncle indentation which leads to ipsilateral third nerve palsy and ipsilateral hemiparesis. Okay, so what? Contralateral cerebral peduncle indentation leads to ipsilateral third nerve palsy, ipsilateral hemiparesis. This is Kernohan's notch phenomena. Okay, so there is contralateral cerebral peduncle indentation and it leads to ipsilateral third nerve palsy and ipsilateral hemiparesis. Hemiparesis. What are the questions which are asked? That it is associated with which type of herniation, uncal or transtentorial herniation? What are the features? So there is ipsilateral third nerve palsy and ipsilateral hemiparesis. Now what happens in Kernohan-Voltman sign? In this case there is lateral displacement of midbrain, and because of this lateral displacement of midbrain there is compression of opposite cerebral peduncle. And if there is compression of opposite or contralateral cerebral peduncle, here this patient is having hemiparesis are going to develop hemiparesis contralateral to original hemiparesis, and this patient is having positive Babinski sign. So what are the features of Kernohan's Voltman sign? There is hemiparesis contralateral to original hemiparesis and it is having positive Babinski sign. What's the cause? It's lateral displacement of midbrain leading to compression of contralateral cerebral peduncle. So these are two very important topics. One is Kernohan's notch phenomena and the second is Kernohan-Voltman sign. In this image, you can see that there are areas of bleeding involving the ventral aspect and paramedian aspect of upper brainstem. Upper brainstem is there is involvement of midbrain and pons. And what's the name of this hemorrhage? Yes, this is known as Durette hemorrhage. Very important topic, asked many times in PGI Chandigarh, in AIIMS. This is Durette hemorrhage. In this image, you can see that there are small areas of bleeding involving ventral aspect and paramedian aspect of upper brainstem. And this upper brainstem is including midbrain and pons. Okay. So what's the name of this hemorrhage? This is known as Durette hemorrhage. How to remember Durette hemorrhage? The easiest way to remember is by 3B. So what's the problem here? There is increased intracranial tension. Because of this increased intracranial tension, there is downward displacement of what? Brainstem. And because of this downward displacement of brainstem, there is stretching of perforators of basilar artery. So what? There is stretching of perforators of basilar artery. And because of stretching of perforators of basilar artery, there is bleeding. So what are the 3Bs? Brainstem, basilar artery, bleeding. Increased intracranial tension leading to downward displacement of brainstem, leading to stretching of perforators of basilar artery, leading to bleeding. Question: where is the bleeding? In which part of brainstem? So generally there is involvement of upper brainstem. Clear? Which part? Where is the bleeding? It is involving ventral and paramedian part. Ventral and paramedian part, and we discussed upper brainstem is including what? Midbrain and pons. So this is Durette hemorrhage. Now we are going to discuss brain tumors. You know that majority of brain tumors occur sporadically. So majority of brain tumors occur sporadically. Okay. What are the risk factors for brain tumors? Two important risk factors are, first, radiation exposure, and the second is genetic abnormalities. So it's the radiation exposure and the second is genetic abnormalities. Genetic abnormalities. Okay. In exam, this question is frequently asked, that what are those genetic conditions which are going to increase the risk of brain tumors? So the genetic abnormalities which are going to increase the risk of brain tumors, first is retinoblastoma, second is Li-Fraumeni syndrome, third is neurofibromatosis. Both neurofibromatosis 1 as well as neurofibromatosis 2 are going to increase the risk. Third is MEN1 syndrome, and we discussed MEN1 syndrome is going to increase the risk of which particular tumor? It is associated with what? Pituitary adenoma. MEN1 pituitary adenoma. Turcot syndrome we discussed. it increased the risk of brain tumor. If we see FAP, in FAP there is increased risk of what? Medulloblastoma. And if we see HNPCC, in HNPCC there is increased risk of what? Glioblastoma multiforme. Okay, next is VHL syndrome, and this VHL syndrome is going to increase the risk of cerebellar hemangioblastoma. Is the cerebellar hemangioblastoma. Next is Gorlin syndrome and tuberous sclerosis. Clear? So how to remember? The mnemonic is RL not in MTVGT. RL not in MTVGT. R retinoblastoma, L Li-Fraumeni syndrome, N neurofibromatosis, M MEN1, T Turcot syndrome, V VHL syndrome, G Gorlin syndrome, and T tuberous sclerosis. Now see the important one-liner questions which are asked related to brain tumors. First question, what's the most common brain tumor and what's the most common spinal tumor? In both of these cases, answer is same, metastasis. So the most common brain tumor is what? It's the metastasis, also known as secondaries. If there is secondaries to brain, what's the most common primary? Most common primary for brain metastasis, we discussed carcinoma lung followed by carcinoma breast. Carcinoma lung followed by carcinoma breast. Now see the twist in the question. Most common primary for leptomeningeal metastasis, in which there is involvement of meninges. So here it is CA breast. You have to remember. Most common primary for brain metastasis, carcinoma lung. For leptomeningeal metastasis, carcinoma breast. Important question. What is the most common primary brain tumor? And you know it is meningioma, responsible for 35% cases, followed by glioma, responsible for 30% cases. So this is meningioma followed by glioma. Okay, what is the most common malignant brain tumor in children? In children, most common malignant brain tumor, and the same brain tumor is most radiosensitive brain tumor also, and the answer is same for both of these. It's medulloblastoma. Medulloblastoma is the most common malignant brain tumor in children, seen in 3 to 4 years of age, and this is most radiosensitive brain tumor. So what is the most common suprasellar mass in adults? That's pituitary adenoma. Yes. And what is the most common suprasellar mass in children? It's craniopharyngioma. Craniopharyngioma. Okay. One of the very important property of craniopharyngioma is that it is associated with calcification. What percent? Almost all craniopharyngiomas are associated with calcification. Not only craniopharyngiomas, there are 3 tumors which are associated with calcification. And how to remember? Mnemonic is COM. C. Craniopharyngioma, O. Oligodendroglioma, and M. Meningioma. You have to remember mnemonic is COM. These are the brain tumors which are associated with calcification. What percentage of craniopharyngioma? Almost all. What percentage of oligodendroglioma? Approximately 90%. And what percentage of meningioma? 20 to 25%. Now see the spinal tumors. We discussed most common brain tumor as well as spinal tumor is metastasis. So answer is same for both brain tumor as well as for spinal tumor. Okay, next question is, what's the most common site of primary spinal tumor? And this is intradural extramedullary. You have to remember intradural extramedullary. Clear? So these are the important one-liner questions related to brain tumors. Now let's discuss the clinical feature, diagnosis and management. Broadly speaking, majority of brain tumors have similar presentation. Yes, similar presentation. Investigation of choice is same. That's MRI, and the treatment is broadly similar. Broadly. So we are going to discuss the clinical feature, diagnosis and management. There are three cardinal symptoms of brain tumor. One is seizure. Second is increased intracranial tension leading to headache. And the third is focal neurological deficit. Seizure, headache, focal neurological deficit, these are the three cardinal symptoms. Okay, this headache, generally it is worse in morning and it's worse after straining. So it is worse in morning and after straining. These are the characteristic features after straining. And this headache, it is associated with nausea and vomiting. Okay, third feature is what? Focal neurological deficit. Focal neurological deficit is important point. It is progressive. What kind of focal neurological deficit? It is progressive. And the type of focal neurological deficit, what is the type? It depends on the location. Focal neurological deficit depends on the location of tumor. Cardinal symptoms. Fourth, imagine a patient who is having pituitary adenoma. If patient is having pituitary adenoma, in that case you will find endocrinologic abnormalities also. Clear? So these are the clinical features. Investigation of choice for diagnosis is same for brain as well as spinal cord tumors, and that's MRI. That's MRI. The management aspect of brain tumor consists of what? Medical management, surgical management, and there are certain tumors in which we have to give radiotherapy. So see the management aspect. What are the drugs which are used in brain tumor? First, dexamethasone. It is going to decrease the peritumoral edema by stabilizing cell membrane. So first, we use this dexamethasone. It decreases the peritumoral edema by stabilizing cell membrane. Anti-epileptics are not used for all brain tumors. It is used for the tumors which are very close to sensory motor strip. So the tumor located very close to sensory motor strip, these tumors are having increased risk of seizures, and that's why we use anti-epileptics. Mannitol, this question is asked many times in exam. Why we use mannitol in neurosurgery? It's used for osmotherapy. You know, mannitol is hypertonic solution. Okay, so it is going to decrease the edema by decreasing the intracranial pressure. Okay, hypertonic solution, it is used for osmotherapy. So mannitol decreases intracranial pressure, it decreases edema. Surgery. In brain tumors, what's the mainstay of treatment? It's the surgical excision. Why? First, you go for surgical excision, then you can get the histopathological diagnosis. So for histopathological diagnosis, surgery is done. Second, it is going to decrease the tumor burden or tumor load. So surgery, it's done for histological diagnosis, and it is going to decrease the tumor burden. It means there is reduction of mass effect. Reduction of mass effect. And if the question is asked, what's the mainstay of treatment in brain tumors? It's the surgery or surgical excision, which is mainstay of treatment. Okay, there are certain special situations where we give radiotherapy in general, in which case you give radiotherapy when you remove the tumor, some part is left. It means if there is positive margins. So tumors which are having positive margins, in post-operative period we give radiotherapy. Second, there are certain brain tumors which are going to encroach the normal brain tissues like glioblastoma multiforme. So there is a role of post-operative radiotherapy. And in which patients we give post-operative radiotherapy? If there is positive margins, or if the tumor is going to encroach, tumor encroaching normal brain tissue. Okay, tumor encroaching normal brain tissue like glioblastoma multiforme. Clear? There are certain tumors in which there is CSF spread, and if there is CSF spread, we go for craniospinal irradiation. This CSF spread is also known as drop metastasis. So what are the tumors which are associated with CSF spread, in which we give craniospinal irradiation? So the mnemonic is CPM germ cap. It's CPM germ cap. Okay, these are the tumors having CSF spread. C, CNS lymphoma. P, pinealoblastoma. M, medulloblastoma. Germ, that is germ cell tumor. C, it's choroid plexus carcinoma. A, anaplastic ependymoma. And P, it is PNET, also known as primitive neuroectodermal tumor. Clear? So these are the tumors associated with CSF spread, in which we go for craniospinal irradiation. Now we are going to discuss brain tumors one by one. First, what are the tumors which are included in glioma? In glioma, we include astrocytoma, oligodendroglioma, and ependymoma. So let's first discuss astrocytoma. So here, the term is self-explanatory that astrocytoma arises from astrocytes. Astrocytes. The characteristic features of astrocytoma in adults and children are almost totally different. See one by one. If we see the location, in adults, astrocytoma is supratentorial, and in children, it is infratentorial. First difference, adults supratentorial, children infratentorial. If it is supratentorial in adults, what's the most common site? Cerebral cortex. In children, it's infratentorial. So what is the most common site? It is cerebellum. This is cerebellum. What is the most common type of astrocytoma in adults? Glioblastoma multiforme, and you know that it is having worse prognosis. This is most malignant type of astrocytoma having worse prognosis, and in children it is pilocytic astrocytoma. Which one? Pilocytic. And pilocytic astrocytoma is having best prognosis. It's associated with best prognosis. So see these images. These are the images of radiological images of glioblastoma multiforme. Glioblastoma multiforme is the most common type of astrocytoma in adults. It is most malignant, having worst prognosis. See the questions related to pathology. In glioblastoma multiforme, there is endothelial proliferation and necrosis. And whenever we perform the investigations, what you see, you are going to notice that there is central necrosis with ring-like enhancement. What? There is central necrosis. What? And there is ring-like enhancement. Right? Second feature, that the tumor is going to cross midline. See the appearance here. It crosses midline, and if you see the appearance, it is looking like butterfly. So it crosses midline, also known as butterfly tumor. So important features which are asked in exam. First, that there is central necrosis. You saw in the first image with ring-like enhancement. So there is ring-like enhancement. Simple. And if you see the second picture, here you can see the tumor is crossing midline. This is also known as butterfly tumor. It's also known as butterfly tumor. How we treat glioblastoma multiforme? We go for cytoreductive surgery followed by external beam radiotherapy. Why? Because there is encroachment of normal brain tissue. So we go for cytoreductive surgery followed by external beam radiotherapy. There is a new agent which is used in some patients of oligodendroglioma as well as glioblastoma multiforme, and that is temozolomide. This temozolomide is used for newly diagnosed and recurrent glioblastoma multiforme. So what kind of newly diagnosed and recurrent glioblastoma multiforme. This temozolomide is also used in oligodendroglioma. Now see oligodendroglioma. First question, what is the most common site of oligodendroglioma? It's the frontal lobe. And what is the most common symptom? It's the seizure. So most common site, it's frontal lobe, and the most common symptom is the seizure. Okay. In how many patients there is calcification? So we discussed up to 90% patients, or up to 90% patients who are having oligodendroglioma, calcification is seen. The most common genetic alteration in oligodendroglioma, it is the loss of heterozygosity on chromosome number 19q followed by 1p. Loss of heterozygosity on chromosome number 19q followed by 1p. If this genetic alteration is there, it's associated with good prognosis. Why? Because these tumors are having robust response to temozolomide. If this kind of genetic alteration is there, there is robust response to temozolomide, and that's why it is associated with good prognosis. We discussed for brain tumors, investigation of choice is what? MRI. Here also investigation of choice is MRI. But you want to see the calcification, and you know, for calcification, what is the investigation of choice? It is CT. What are the important pathological features? There is fried egg cytoplasm, there is chicken wire vasculature, and microscopic calcification. Fried egg cytoplasm, chicken wire vasculature. Clear? So it appears that the tumor is non-veg. So how you can remember that oligodendroglioma is a non-veg tumor characterized by fried egg, characterized by chicken. So fried egg cytoplasm, chicken wire vasculature, and microscopic calcification. These are important pathological features of oligodendroglioma. Now ependymoma. Ependymoma arises from ependymal linings of cerebral hemispheres and the central canal of spinal cord. Ependymoma so arises from ependymal linings. What's the most common site in children? It's the fourth ventricle. In children, it's the fourth ventricle. And what is the most common histological type in adults? It is the myxopapillary ependymoma. Myxopapillary ependymoma. And what is the most common site of this myxopapillary ependymoma? Means from where it is going to arise? So it is going to arise from phylum terminale of lumbosacral region. Phylum terminale of lumbosacral region. See the relation of this tumor. It is arising from ependymal lining of cerebral hemisphere and central canal of spinal cord. It means it is in relation to CSF. So important feature that this tumor is having CSF spread. And if the tumor is having CSF spread, so what should be used in the treatment? We use craniospinal irradiation. So in the patients of ependymoma, we use craniospinal irradiation. Why? Because there is CSF spread of the tumor. We discussed medulloblastoma, that is the most common malignant brain tumor in children, and this is most radiosensitive brain tumor. Generally, it is seen in 3 to 4 years of age. What particular age group? 3 to 4 years. And we discussed it is associated with one condition. Which one? Turcot syndrome. Especially in which patients? In patients of FAP. Right? Now, what is the most common site overall, and what is the most common site in adults? So overall, the most common site is vermis. What? Vermis. So indirectly question will be asked that what is the most common site of medulloblastoma, or what is the most common site of medulloblastoma in children? So it's vermis. Overall, it's most common site, and in children also. Clear? So in children, or overall most common site is vermis. And if you're talking about adults, in adults is the lateral cerebellar hemisphere. What is the most common site? It's the lateral cerebellar hemisphere. Okay. Now see the clinical features. In children, the location is in the vermis. In children, there is increased intracranial tension, and because of increased intracranial tension, what happens? There are signs and symptoms of raised intracranial tension. So symptoms in children, there are signs and symptoms of raised intracranial tension. What? Like there is headache, and because of raised intracranial tension, which sign? Papilledema and headache. In adults, it is lateral cerebellar hemisphere. That's why adults are having ataxia and unilateral dysmetria. So in adults, because of location, there is ataxia and unilateral dysmetria. Ataxia and unilateral dysmetria. And similar to ependymoma, in medulloblastoma also what? CSF spread is there. There is drop metastasis, and that's why we give craniospinal irradiation in medulloblastoma also. We discussed that the most common primary brain tumor is meningioma followed by glioma. Meningioma responsible for 35% cases, gliomas responsible for 30% cases. You know, this meningioma is the most common intracranial, extraaxial, dural based neoplasm. Okay, and from where it is going to arise? From meningomesothelial cells of arachnoid located along superior sagittal sinus. In how many patients you are going to find calcification? 20 to 25% patients have calcification. There is special property in meningioma that there is dystrophic calcification, and you know, this dystrophic calcification is also known as which bodies? This is known as Samoma bodies. So in meningiomas you are going to find what? Samoma bodies. Questions are frequently asked related to clinical features and presentation. Meningiomas are more common in females age group around 40 to 50. Okay, see the clinical presentation. In 90% patients, there is motor deficit, and in 60% patients, there is sensory deficit. What kind of motor deficit is there in patients of meningioma? These patients have spasticity, and there is lower limb weakness. There is spasticity and lower limb weakness. Apart from motor deficit and sensory deficit, there is sphincter dysfunction of bladder. So the question will be like this, that a 40 years old female presented to your OPD or emergency with paraparesis. There is sensory deficit in the perineal region with sphincter dysfunction of bladder. What is the diagnosis? And sometimes they give image also, right? So you will find this image also. And here you can see what? Meningioma is dural based neoplasm, and here you can see dural tail. Dural tail sign is seen in meningioma. So can you see here? This is dural tail. Apart from dural tail sign, there are other radiological appearances which are important and asked in exam. You saw dural tail sign. Then is bony hyperostosis, and because of this bony hyperostosis, the appearance is like sunrise spicules. There are signs of raised intracranial tension, and you are also going to find enlarged foramen spinosum. And in how many patients there is presence of calcification? In 20 to 25% patients you are going to find the calcification. Generally, meningiomas are treated by surgical excision. There is important grading which is performed for meningioma, that is Simpson grading. So Simpson grading, it is used for meningioma. So we discussed that the most common brain tumor is metastasis or secondaries. What is the most common primary for brain metastasis? Is the carcinoma lung, we discussed, followed by carcinoma breast, and we discussed that what is the most common primary for leptomeningeal metastasis? That is carcinoma breast. Okay. Apart from these important points, see what's the most common site of brain metastasis. It is cerebral cortex, and in the cerebral cortex, what's the most common site? Frontal lobe. So you have to remember that oligodendroglioma most common site is also frontal lobe, and in metastatic brain tumor also most common site is frontal lobe. So overall most common site is frontal lobe of cerebral cortex, followed by cerebellum, followed by brainstem. So most common site is frontal lobe. Okay. Investigation of choice for diagnosis is same, MRI. So here we are using gadolinium contrast, MRI with gadolinium contrast. Typically, you are going to find the metastasis at the junction of gray matter and white matter. So what's the location? It's gray matter, white matter junction. In this image, you can see that this is the target lesion in the brain. And here what we are using, the radioactive cobalt source. So radioactive cobalt is used, and this is used for production of which rays? Gamma rays. This is also known as gamma knife. It's gamma rays, also known as gamma knife. Okay, so here you can see that gamma rays are converging. So precisely targeted concentrated dose of radiotherapy is given to this small volume of brain which is having the pathology, and this is known as stereotactic radiosurgery. It's not a type of surgery, it's a type of radiotherapy. It means it's a type of non-surgical radiotherapy in which we are going to deliver precisely targeted concentrated dose of radiotherapy. What are the forms of frame-based stereotactic radiosurgery? In one, we are using cobalt 201. So radioactive cobalt is used for production of gamma rays, and that's gamma knife. And in second, we use modified linear accelerator. Modified linear accelerator. And these are going to produce high energy X-rays. Okay, these are the forms. Generally, in which cases we are using this stereotactic radiosurgery, which is non-surgical radiotherapy? See the indications. The common uses are small brain tumors, benign lesions of cranial nerves, AV malformations, and trigeminal neuralgia. So how to remember? The mnemonic is BAT. Brain tumors, generally small brain tumors, benign lesions of cranial nerves, AV malformations, and trigeminal neuralgia. So these are the common uses of stereotactic radiosurgery, and this is all about neurosurgery. Now we are going to discuss the important topics of oral cavity. First, see the one-liner questions asked related to carcinoma oral cavity. So what's the most common mutation in carcinoma oral cavity? It is P53. And you know what is the most common histological type of oral cavity? It is lined by squamous epithelium. So most common histological type, squamous cell carcinoma. It is squamous cell carcinoma. If you see the site, most common site of carcinoma oral cavity, worldwide it is tongue followed by lip. Worldwide. And in India, it is buccal mucosa, also known as cheek. So read the question carefully. Worldwide, it is tongue followed by lip. And if it's asked in India, it is buccal mucosa. Okay, it's the buccal mucosa or cheek. Sometimes you will get this in option, cheek. What is the most common pattern of spread? So generally in carcinoma oral cavity, there is local extension and lymphatic spread. So what kind of spread? Most common pattern is local extension, and you will find that there is lymphatic spread, right? Hematogenous spread also occurs. If hematogenous spread occurs, it is responsible for distant metastasis. And what is the most common site of distant metastasis? It's lungs. So most common site of metastasis, that's lungs. There are two set of questions. First, what is the most common malignancy in oral cavity which is associated with lymph node metastasis? So most commonly associated with lymph node metastasis, it's carcinoma tongue. So carcinoma tongue in oral cavity is most commonly associated with lymph node metastasis. And which one is least commonly associated with lymph node metastasis? It's carcinoma lip. This question was asked in AIIMS, and carcinoma lip was not there in the option. So what you will choose if lip is not there? hard palate. If carcinoma lip is not there, choose hard palate. So CA tongue, carcinoma tongue, most commonly associated with lymph node metastasis. Carcinoma lip followed by hard palate, least commonly associated with lymph node metastasis. Now see this simple diagram. This is lip, okay? This is the philtrum. Now what is the problem? If you see the upper lip, there is lymph node metastasis to ipsilateral side. But if you see the lower lip, in the lower lip there are crisscross connections. And because of this crisscross connections, what happens? There is bilateral lymphatic spread. Not only lower lip, even in supraglottis, even in soft palate, and in urology we discussed carcinoma penis. Because of crisscross connections in all these malignancies, there is bilateral lymphatic spread. So what are the malignancies having bilateral lymphatic spread in oral cavity? Carcinoma lower lip. This is carcinoma lower lip. Second is soft palate, and the third is supraglottis. In oral cavity, 3 malignancies. Supraglottis, and you have to add additional, which we discussed in urology, even in carcinoma penis, because of crisscross connections, what? Bilateral lymphatic spread is there. Now see, the malignancy is accessible in the oral cavity. Investigation of choice for diagnosis is biopsy. We are not taking biopsy from the center because there is presence of necrotic tissue. So we are taking the biopsy from one edge. So what kind of biopsy? It's the edge biopsy. Okay. Another important question. Investigation of choice for staging of head and neck malignancies like CA oral cavity, like salivary gland tumors. So not only in head and neck malignancies, 2 important questions. There is overcrowding of nerves, muscles, vessels, soft tissues in head and neck region and in pelvis. And that's why investigation of choice for staging of head and neck malignancies and pelvic malignancies, it's MRI. It's MRI. Okay. After that, in head and neck malignancies, generally we go for, since the type is squamous cell carcinoma, in majority of cases we go for wide local excision. If you go for wide local excision, generally what happens, at the site of malignancy there is a defect. So how we are going to manage the defect? We are taking a flap. So what is the most commonly used flap for head and neck reconstruction? Reconstruction of head and neck defects, and that is PMMC flap, pectoralis major myocutaneous flap. So important question, most commonly used flap for reconstruction of head and neck defects, and that's PMMC flap. It's pectoralis major myocutaneous flap, and it is based on pectoral branches of, so it is based on pectoral branches of thoracoacromial vessels. Thoracoacromial vessels, right? These are one-liner questions which are very, very important, almost asked every year. You must be knowing the story of Mukesh. You have seen that ad in theaters, yes? So generally you see in UP and Bihar, youngsters from class 10th, class 11, they start chewing gutka or tobacco. So what is the problem? In North India especially, there is high incidence of carcinoma oral cavity, right? So what are the risk factors? You can see it's tobacco, alcohol, betel nut, erica nut, use pan masala. All these are the risk factors. If somebody is having jack tooth, sharp jack tooth, it leads to irritation and it also increases the risk of malignancy. There is Plummer-Vinson syndrome. Plummer-Vinson syndrome increases the risk of squamous cell carcinoma. Not in the oral cavity, it is going to increase the risk of carcinoma oral cavity, hypopharynx and esophagus. It is going to increase the malignancy in oral cavity. Second, in hypopharynx and esophagus. And histological type is same. And what's that histological type? Is the squamous cell carcinoma. If a patient is having ill-fitting dentures, patient is having syphilitic glossitis, these are going to increase the risk of carcinoma oral cavity. There are two viruses. One is human papilloma virus infection and second is Epstein-Barr virus infection. Both of these viruses are going to increase the risk of squamous cell carcinoma. Poor nutrition is also a risk factor, and if you remember, this question was asked in a latest exam, that whether vitamin A deficiency is a risk factor for carcinoma oral cavity or not. Yes, vitamin A deficiency is a risk factor. So this is the list of risk factors for carcinoma oral cavity. This image is very important, and almost each year there is one question from this image. So here you can see in the first, there is presence of whitish patch or whitish plaque located along the lateral aspect of tongue. This is what? Leukoplakia. So whitish patch or whitish plaque which cannot be rubbed off, that is leukoplakia. In the second image you can see there is presence of this reddish plaque or patch, and this is what? Erythroplakia. And if you see the third image here, leukoplakia is having erythematous base, or if you see there are reddish areas also, these are reddish areas, and there is whitish patch also. Clear? So in the third image you can see that leukoplakia having erythematous base, or sometimes there is erythroplakia having whitish patches. So this is known as speckled erythroplakia, also known as speckled leukoplakia, also known as erythroleukoplakia. Clear? So first is leukoplakia, second is erythroplakia, third is speckled erythroplakia, also known as erythroleukoplakia. Problem: if we compare the incidence, most common is in these three, the most common is leukoplakia. And which one is most malignant? The most malignant is speckled erythroplakia. This is most malignant. Clear? After speckled erythroplakia, if you see the risk of malignancy, it is erythroplakia, and the least risk is there in the leukoplakia. Why there is risk in erythroplakia? Because these patients have severe dysplasia, right? Because of this severe dysplasia, there is increased risk of malignancy in erythroplakia. So if you see erythroplakia, leukoplakia, speckled erythroplakia, all these three are going to increase the risk of carcinoma oral cavity. Maximum risk is seen in speckled erythroplakia, followed by erythroplakia, followed by leukoplakia. There are pathological changes sometimes asked in relation to leukoplakia. What? There is hyperkeratosis, there is parakeratosis and acanthosis. Hyperkeratosis, parakeratosis, acanthosis. So obviously dysplasia, hyperkeratosis, parakeratosis, acanthosis, all these changes are visible on histopathological examination. So what is the investigation of choice for diagnosis of these conditions? Biopsy. Clear? Another important condition which is going to increase the risk of carcinoma oral cavity, that is Plummer-Vinson syndrome. What are the other names of Plummer-Vinson syndrome? It is also known as Patterson-Brown-Kelly syndrome, also known as sideropenic dysphagia. Sideropenic. So in this patient actually there is iron deficiency anemia. Sideropenic, and there is upper esophageal web, and this upper esophageal web is responsible for dysphagia. That's why it's known as sideropenic dysphagia. We discussed that it is going to increase the risk of squamous cell carcinoma of oral cavity. What else? Hypopharynx and esophagus. It's very important. It is asked in pathology, asked in medicine, asked in surgery. See the characteristic features of Plummer-Vinson syndrome. So it is Plummer-Vinson syndrome is characterized by splenomegaly. There is achlorhydria. There is dysphagia. We discussed what's the cause of dysphagia. There is upper esophageal web. And there is chronic iron deficiency anemia, and that's why we call it sideropenic. Okay, and that's why the term is sideropenic dysphagia. There is atrophic oral mucosa, sometimes there is inflammation, and there is glossitis, okay, and there is koilonychia, spoon-shaped brittle nails. So these are the associations, characteristic features. So how to remember? The mnemonic is SAD CA coil. It's the SAD CA coil. So S splenomegaly, A achlorhydria, D dysphagia, C chronic iron deficiency anemia, A atrophic oral mucosa, and coil, that is koilonychia. See this image, this is another pre-malignant condition for oral cavity. So this is oral submucous fibrosis, which is going to increase the risk of carcinoma oral cavity. Typically, it is seen in Asian population, more common in females, especially the patients who are having the habit of chewing areca nut or betel nut. Because of that, there is chronic irritation, and in this, there is formation of what? Fibrous band. So the name is oral submucous fibrosis. So what happens? There is formation of fibrous band beneath the mucosa. So formation of submucous fibrous bands. And because of formation of these fibrous bands, this patient is having restricted mouth opening and restricted tongue movement. Imagine a female who is having restricted mouth opening and restricted tongue movement. You can understand the pain of that female patient. So what's the problem here? There is presence of fibrous bands leading to restricted mouth opening, and not only mouth opening, there is restricted tongue movement. Okay, typically it is seen in Asian population with the use of areca nut. Now how we are going to treat it? One, we can inject the steroid, intralesional injection of steroid. Which one? Triamcinolone. So one is we go for intralesional injection of triamcinolone, okay, and there is alternative treatment. What? We have to go for the excision of these fibrous bands, and we go for grafting. So alternative treatment is what? Excision followed by grafting. So this is how we manage oral submucous fibrosis. It's a pre-malignant condition for carcinoma oral cavity. We discussed that the most common site of carcinoma oral cavity worldwide is tongue followed by lip. Here you can see there is presence of ulcer over the lateral aspect of tongue, and in the lip you can see what? There is this kind of lesion, right? So what is the presentation in patients who are having carcinoma oral cavity? Either patient is coming to you with some kind of swelling, persistent swelling because of the lesion, because of the lymph node, or there is ulcer, and generally duration is more than 3 weeks. So it's of more than 3 weeks duration. If there is ulcer in the tongue, so what's the problem? Patient is having sore tongue, patient is not able to tolerate hot and spicy food, there is difficulty in swallowing. Yes, there is local extension of tumor, and if there is local extension, because of this local extension, you are going to notice that there is either jaw swelling or facial swelling. Sometimes it is associated with lymph node metastasis, and if there is lymph node metastasis, you are going to palpate, or patient comes with painless mass in the neck. In advanced stages, there is difficulty in opening of mouth, that's trismus. Simple. These are the clinical features. We discussed how we are going to make the diagnosis of C oral cavity, edge biopsy. We discussed how we are going to perform the staging, investigation of choice for staging, that's MRI. Now see the management. It's very easy to remember the management of carcinoma oral cavity. If we see in general, for T1 and T2 lesion, what is sufficient? Surgical excision. For T1 and T2 lesions, surgical excision, that's sufficient. And for T3 and T4 is the surgical excision plus radiotherapy. Generally, this is the management. What's the mainstay of treatment in carcinoma oral cavity? The mainstay of treatment is surgical excision with flap reconstruction. So what we go for, the mainstay of treatment is the surgical excision or wide local excision plus reconstruction. Okay, so wide local excision plus reconstruction. This is the main treatment option or most important treatment option. In this image you can see these are the pectoral branches of thoracoacromial artery. Okay, and this is pectoralis major myocutaneous flap. In this patient there is malignancy of cheek, so after wide local excision there was defect here, so this pectoralis major myocutaneous flap is used for reconstruction. So here you can see after the use of flap, this is the defect, yes, and here the reconstruction has been done. So for most of head and neck malignancies, the reconstruction is done after wide local excision. And what is the most commonly used flap? Pectoralis major myocutaneous flap, which is based on pectoral branches of thoracoacromial artery. Second treatment option is chemotherapy. Okay, and what is the most preferred chemotherapy regimen? The most preferred chemotherapy regimen is what? It's the cisplatin plus 5-fluorouracil. So it's the cisplatin plus 5-fluorouracil. You are going to hear two terms in relation to management of carcinoma oral cavity. One is concurrent chemotherapy and the second is concurrent chemoradiation. Both concurrent chemotherapy as well as concurrent chemoradiation are used for C oral cavity. Both of these are used. Right? Now see the comparison. If we give concurrent chemotherapy and we give concurrent chemoradiation, which one is preferred or having better survival? So it's the concurrent chemoradiation which is preferred over concurrent chemotherapy. So concurrent chemoradiation is having better survival advantage over chemotherapy alone, or in radiotherapy we use external beam radiotherapy. In carcinoma oral cavity we use external beam radiotherapy. How much is the dose we give? We give 60 gray and this dose is administered over 6 weeks. So 60 gray of radiotherapy, it's given over 6 weeks. What's the problem with What's the problem with radiotherapy? That there are some complications and these complications are frequently asked in exam. First question, what's the most common complication of radiotherapy in carcinoma oral cavity? And it is xerostomia. Other complications, radiotherapy can lead to inflammation, that is mucositis, dysgeusia, there is altered taste, and this can be temporary or permanent. This complication is frequently asked, and what's that? Osteoradionecrosis of jaw. In which particular region it is seen if a patient is having caries tooth? Right? So generally in the radiation field, if a patient is having caries tooth, there is increased risk of osteoradionecrosis, and this condition is associated with decreased production of saliva. This is the picture of carcinoma lip, and you know, in carcinoma lip, what is the most common site? It's the lower lip. Why? It is more common in the lower lip because of direct ultraviolet exposure. So ultraviolet rays exposure to the lower lip, it is more common in the lower lip. Exactly where? You can see at the vermilion border. So in the lower lip, exactly where? In the vermilion border. Because of outdoor activities, it is more common in males. So most common site, lower lip, near vermilion border. It is more common in males because of outdoor activities. What is the presentation? So we discussed, sometimes you will notice a swelling or sometimes ulceration. So see the clinical features. Here you can notice swelling or ulceration. So it is swelling or ulceration. Okay, we discussed that in upper lip lymphatic spread is there, but it is going to involve the ipsilateral lymph nodes. And what's the problem in lower lip? Because of crisscross connections. What? Because of crisscross connections, bilateral lymph nodes can be involved. Simple. Investigation of choice is same, it's H biopsy. Investigation of choice for staging is same, it's MRI. Now coming to the treatment. We discussed for T1, T2, what's the treatment? Only surgery. And for T3, T4, it's the surgery plus radiotherapy. Okay. So we discussed in the management that for T1, T2, surgery is sufficient, and for T3, T4, we go for surgery plus radiotherapy. In T1 and T2 lesions, if there is involvement of lip less than 1/3 or 1/3, in that case we go for V-shaped or W-shaped excision with primary closure. And whenever more than 1/3 of lip is involved, in that case we go for excision plus reconstruction. Excision plus reconstruction. And if it's involving 1/3 up to 1/3 of lip, here we go for V-shaped or W-shaped excision plus primary closure. It's the primary closure. Okay. See how we are going to do this. In this image you can see that this is the tumor. It is involving lip. How much is the involvement? Up to 1/3. And what kind of excision? Can you see? W-shaped excision is done, and after that we go for primary closure. So W-shaped excision with primary closure. Now see the second image. In this image you can see this is the lesion. Okay. And what kind of excision is done? It's the V-shaped excision. After this V-shaped excision, what? You can see that primary closure is done. See this image here. More than 1/3 of lip is involved. Since more than 1/3 of lip is involved here, you can see we are going to excise. Okay. We are going to excise the lesion. After that, I'm taking this upper lip, which is based on superior labial artery, for reconstruction of this lower lip. So here you can see the flap has been taken for reconstruction of this lower lip. And what's the name of this flap? This is Abbe-Easterlander's flap. So the name of this flap is Abbe-Easterlander's flap. And this Abbe-Easterlander's flap, it's based on superior labial artery. It is based on superior labial artery. So this is based on superior labial artery, right? This is how we perform the reconstruction. There are circumoral advancement flaps also known as Webster-Bernard flap or Karpanzig flap. But this is cross lip flap known as Abbe-Easterlander flap based on superior labial artery. This is carcinoma tongue, and we discussed it is most common type of oral cavity malignancy worldwide. Okay, see the most common site. This is the tongue. It is further divided into anterior 1/3, middle 1/3 and posterior 1/3. This is anterior 1/3, this is middle 1/3, and this is the posterior 1/3. What is the most common site? Here you can see the most common site is lateral aspect of junction of middle and posterior 1/3. So the most common site is the junction of middle and posterior 1/3. Which aspect? Lateral aspect. Lateral aspect of junction of middle and posterior 1/3. Generally, it presents as ulcer. So which type is most common? It's the ulcerative variety. Most common type is ulcerative variety. Okay. See the most common group of lymph node involved in carcinoma tongue. It's level 2. And what is this level 2? It's upper jugular lymph node. So level 2 lymph nodes are most commonly involved. Since there is ulcer and this ulcer fails to heal, this patient cannot tolerate hot and spicy food. How we are going to make the diagnosis? H biopsy, investigation of choice for staging, yes, MRI. Now see the management. Now imagine this is the tongue, and if it is T1, the lesion is T1, in that case what we go for? We go for partial glossectomy. So in T1, we go for partial glossectomy. If it is T2, in that case, we go for hemiglossectomy. So half of tongue is excised. Here you can see, we go for hemiglossectomy. So for T2, apart from going for hemiglossectomy, we give radiotherapy also. Whenever it's T3, in T3, we have to excise the whole tongue, right? So we go for total glossectomy, simultaneously we go for mandibulectomy. And whenever there is T4, in that case, apart from total glossectomy and mandibulectomy, we perform modified radical neck dissection, MRND, modified radical neck dissection. We remove larynx, that is laryngectomy, and we give radiotherapy. So this kind of extensive surgery is done for T4. This is how we manage patients of carcinoma tongue. Here you can see this is a case of carcinoma buccal mucosa or cheek. And you know, this is the most common type of carcinoma oral cavity in India. Why? Because of use of Chinese khani, some kind of khani in which we are mixing the betel leaves with lime shell, and the quid is placed here near alveobuccal complex. So in India, it's the most common type of carcinoma oral cavity. Most common type of carcinoma oral cavity in India. Okay. Now here, what's the problem? In the lesion, there is minimal pain, but if you see the location, what happens? Sometimes there is obstruction of Stenson's duct, and you know the Stenson's duct is of parotid. So whenever there is involvement of the Stenson's duct, it is going to obstruct Stenson's duct. So in those cases, you are going to find parotid enlargement. Yes, you can find parotid enlargement in patients of carcinoma buccal mucosa, and the management is same. We go for wide local excision in T1, T2, and in T3, T4, apart from surgical excision, we have to go for radiotherapy. So this is how we manage the patients of carcinoma buccal mucosa. And whatever the defect is created after surgery, generally which flap is used? It's PMMC flap, pectoralis major myocutaneous flap. In this image, you can see that there is a mass involving the roof of mouth, actually involving hard palate. So this is carcinoma hard palate. We discussed what is the most common histological type of carcinoma oral cavity, squamous cell carcinoma. But in carcinoma hard palate is different. Why? Because it is arising from minor salivary glands. And what is the most common malignant tumor arising from minor salivary glands? It's adenoid cystic carcinoma. So you have to remember, squamous cell carcinoma in hard palate is rare. The most common type is adenoid cystic carcinoma. Why? Because it's arising from minor salivary gland. So the origin of this tumor is from minor salivary gland. One question, and you know, most common malignant tumor of minor salivary gland, it is adenoid cystic carcinoma, right? So this is adenoid cystic carcinoma, which is most common. Squamous cell carcinoma is rare. One question which is asked related to carcinoma hard palate, what? That you know, some people who are having the habit of reverse smoking, they put the burning end of BD or cigarette in the mouth first. So this is the malignancy which is associated with reverse smoking. What? Reverse smoking. Okay. So this is carcinoma hard palate, and this is all about carcinoma oral cavity. Now we are going to discuss the salivary gland. First, see the important questions related to anatomy. Parotid gland is having serous acini. What kind of acini? Serous. And if you see this submandibular gland, it is having both serous plus mucinous acini. Submandibular gland is having both serous plus mucinous acini. And if you see sublingual gland and minor salivary glands, these are having only mucinous acini. Okay. Second question is related to ducts. So what's the name of parotid gland duct? It's known as Stenson's duct. And where this Stenson's duct is going to open? At upper second molar, near upper second molar. What's the name of submandibular duct? It is Wharton's duct, and it opens at papilla just lateral to frenulum. What are the names of ducts of sublingual gland? It is known as duct of Rivinus or Bartholin's duct. Okay, these are important questions related to anatomy. Now see the one-liner questions related to salivary gland tumors. First question, that what's the most common salivary gland tumor? And you know, it is pleomorphic adenoma. Most common salivary gland tumor, that is pleomorphic adenoma. Okay. Second question is, what's the most common malignant salivary gland tumor? And the most common malignant salivary gland tumor is mucoepidermoid carcinoma. What's that? It's the mucoepidermoid carcinoma. Okay. Now see, the most common neoplasm of salivary gland in children. In children, it's totally different. And what's the name of that neoplasm? It's hemangioma. Most common neoplasm of salivary gland in children, it's hemangioma. The malignant tumor is same in children and in adults, and that's mucoepidermoid carcinoma. So the most common malignant tumor of salivary gland is mucoepidermoid carcinoma. Second most common malignant salivary gland tumor is adenoid cystic carcinoma, and adenoid cystic carcinomas are arising from minor salivary gland. So what is the most common malignant tumor of minor salivary gland? It is adenoid cystic carcinoma. Adenoid cystic carcinoma. There is important point related to salivary gland tumor, that all salivary gland tumors are more common in parotid, with two exceptions. What are those two exceptions? First we discussed adenoid cystic carcinoma. It's the adenoid cystic carcinoma, and you know adenoid cystic carcinomas are more common in minor salivary gland. And the second is squamous cell carcinoma. Squamous cell carcinoma is more common in submandibular gland. Apart from these two malignancies, almost all salivary gland tumors are more common in parotid. Okay, so examples, you know, pleomorphic adenoma, the most common site is parotid. Wardin's tumor, mucoepidermoid carcinoma, acinic cell carcinoma. These tumors are exclusively seen in parotid. These are exclusively seen in parotid. Okay. Lymphoma, metastasis, these are also more common in parotid. So almost all salivary glands are more common in parotid gland except adenoid cystic carcinoma, which is more common in minor salivary gland, and squamous cell carcinoma, which is more common in submandibular gland. What is the investigation of choice for diagnosis in salivary gland tumors? We go for FNAC. It is FNAC. And best imaging investigation for salivary gland tumors, we discussed for head and neck malignancies, generally it is MRI. Okay. See, in salivary gland tumors, especially in the parotid, open incisional biopsy is contraindicated. Why? Open incisional biopsy is contraindicated. It can injure the duct. If there is injury to duct, it can lead to parotid fistula. And second, there is tumor dissemination along the tract. So that's why open incisional biopsy is contraindicated in salivary gland tumor, especially in the parotid. Second important point, the risk of malignancy in salivary glands is inversely proportional to the size of gland. So in parotid gland, what percentage of tumors are benign and what percentage of tumors are malignant? 75% tumors are benign in parotid and only 25% are malignant. If we see submandibular gland and sublingual gland here, 50% tumors are benign and 50% are malignant. And if you see minor salivary gland, only 25% are benign, here 75% are malignant. So risk of malignancy is inversely proportional to size of salivary gland. Now see the management of salivary gland tumors broadly. So out of the given options, what is the principal treatment? Is the surgery, which is the principal treatment. Sometimes surgery alone is sufficient and sometimes surgery in combination with radiotherapy. We perform neck dissection also. So in which cases neck dissection is performed? So if patient is having clinically palpable lymph nodes or there is high grade malignancies. So neck dissection, if there are clinically palpable lymph nodes, okay, or patient is having high grade malignancy, right? In these cases, we go for neck dissection. What's the role of chemotherapy? Let me tell you, this question was asked many times in All India NEET, that there is limited role of chemotherapy in thyroid malignancies and in salivary gland tumors. You have to remember, limited role. Chemotherapy is having limited role in salivary gland tumors and in thyroid malignancies. We give radiotherapy in salivary gland tumors. What are the indications? So it's easy to remember. The radiotherapy will be given in high grade tumors or low grade tumors, obviously high grade tumor, small tumor or large primary tumor, obviously large primary tumor. Apart from these two indications, if there is involvement of nerve, involvement of bone, involvement of lymph node. So there is perineural invasion, bony invasion, cervical lymph node involvement or metastasis, we give radiotherapy. And you know, a general indication of radiotherapy, that after removal of tumor, if positive margin is there, means some tumor is left, we go for radiotherapy. So indications are high grade tumor, large primary tumor, perineural invasion, bone invasion, cervical lymph node metastasis, positive margins. So broadly, this is how we are going to manage the salivary gland tumors. One simple question related to surgery. If the tumor is in the parotid, depending upon involvement of superficial lobe, deep lobe, if superficial lobe is involved, we go for superficial parotidectomy. Deep lobe is involved, deep lobe parotidectomy. In malignancies, generally we go for total parotidectomy. Apart from parotid, if any other salivary gland is involved, what? Generally we go for excision of that salivary gland, right? So you can see, this is one of the incision used for parotidectomy. So what are the names of incisions which are used for parotidectomy? One is lazy S incision. Second is modified Blair's incision, and third is cis trunk incision. It is cis trunk incision. It's not cis trunk operation. We discussed cis trunk operation is performed for thyroglossal cyst, in which we were excising what? Cyst along with central part of hyoid bone. So incisions are lazy S, modified Blair's, and cis trunk incision. This question is asked both in ENT as well as in surgery. Whenever we are performing parotidectomy, we have to be very careful about facial nerve. And there are certain important landmarks. So what are those surgical landmarks for facial nerve? You can see, this is styloid process. Here you can see tragal pointer. There is tympanomastoid suture line, which is the most constant landmark. What's that? Tympanomastoid suture line. This is the most constant landmark. This was the question in AIIMS. Most constant landmark. And here you can see posterior belly of digastric. So what are the landmarks? Styloid process, tragal pointer, tympanomastoid suture line, retromandibular vein, and posterior belly of digastric. How to remember? Mnemonic is strap. Styloid process, tragal pointer, tympanomastoid suture line, R, retromandibular vein, P, posterior belly of digastric. After parotidectomy, there are certain complications which are frequently asked in exam. You know, after parotidectomy, there can be facial nerve paresis or paralysis. There is sensory abnormality. This was the question which was asked in AIIMS, that after parotidectomy, in post-operative period, when patient was doing shaving, patient noticed numbness. This numbness is because of sacrifice of which nerve? So sensory abnormalities are because of sacrifice of greater auricular nerve. It's because of sacrifice of greater auricular nerve. There can be parotid fistula if there is injury to parotid duct, and there can be Fraze syndrome. This Fraze syndrome is frequently asked in exam. We are going to discuss in detail. What are the other names of Fraze syndrome? It is also known as auriculotemporal syndrome, also known as gustatory sweating. Why? Because when patient is smelling food or eating food, there is sweating over the parotid region. The term is self-explanatory. It is because of injury of which particular nerve? Auriculotemporal nerve. What's the problem? See, this auriculotemporal nerve is carrying secretomotor fibers to the parotid. Secretomotor fibers. Second, the sweat glands are supplied by what? The sympathetic fibers. Whenever we are performing the surgery, there is aberrant cross innervation between parasympathetic fibers and sympathetic fibers, and that's why when the patient is eating food, smelling food, what happens? There is sweating over the parotid region, and it is known as gustatory sweating. So in this image you can see these are the sympathetic fibers supplying the sweat glands, and these are the parasympathetic fibers which are having secretomotor fibers for parotid gland. Because of surgery, there is aberrant cross innervation, and whenever there is aberrant cross innervation during meals, there is sweating over this region. How we are going to make the diagnosis of Fraze syndrome? We are going to make the diagnosis by Miner's starch iodine test. It's Miner's starch iodine test. This was the image based question in NEET PG. Here you can see swelling arising from parotid or swelling located in the parotid region. What's the exact location? Swelling in front, below, behind ear lobule, pushing it up. In front, below, behind ear lobule, pushing it up. This is typical of parotid swellings. So this is parotid tumor. What's the most common salivary gland tumor? It's pleomorphic adenoma. And what's the most common tumor seen in parotid gland? It's the pleomorphic adenoma, right? In parotid, what's the most common site? So it's the superficial lobe or tail of parotid. In parotid, the most common site is superficial lobe or tail. It can arise from submandibular gland also, sublingual gland also. Pleomorphic adenoma is also known as mixed tumor. Why? Because it's having both epithelial as well as mesenchymal component. Both epithelial as well as mesenchymal component is there. Another important question which is asked in pathology, see the appearance. This tumor is having this kind of finger-like projection, and this finger-like projection is also known as pseudopodia-like growth. Okay, so this is having pseudopodia or finger-like projections. So what is contraindicated in pleomorphic adenoma? Enucleation. If you go for enucleation, some projections are left which can lead to recurrence. Clear? It's a painless swelling. Pleomorphic adenoma, it's a painless swelling located in front, below, behind ear lobule, pushing it up. Investigation of choice for diagnosis? Yes, it is FNAC we discussed. If the tumor is arising from parotid, we go for what? Superficial parotidectomy. And if it's arising from sublingual gland, submandibular gland or minor salivary gland, we go for excision of involved gland. Here you can see again a swelling in relation to parotid, and this is bilateral. What's the name of this tumor? This is Wardens tumor. Wardens tumor, it is also known as papillary cyst adenoma lymphomatosum. Papillary cyst adenoma lymphomatosum, other name is adenolymphoma. Why it is known as adenolymphoma? Because it is having both epithelial component and lymphoid component. So it is having both epithelial and lymphoid component. We discussed what's the most common tumor of parotid? Pleomorphic adenoma. Wardens tumor is second most common tumor of parotid. It's benign. It's not going to become malignant. Exclusively seen in parotid. This is more common in males. It is more common in smokers, and in 10% cases it's bilateral. In 10% cases, it's bilateral. Investigation of choice for diagnosis is same, that's FNAC. But what's the important point which is asked in exams related to Warden's tumor? That it shows hot spot on technetium pertechnetate scan. Rest all salivary gland tumors are going to show cold spot. So what? It is going to show hot spot on technetium pertechnate scan. Technetium pertechnate scan. Okay, there is hot spot in Warden's tumor. In other salivary gland tumors, there is cold spot, and since it is exclusively involving parotid, it's a benign tumor. So what's the treatment of choice? Is the superficial parotidectomy. You know, mucoepidermoid carcinoma is the most common radiation-induced neoplasm of salivary gland. Okay, and it's the most common malignant tumor of salivary gland, both in adults as well as in children. Both in adults as well as in children. It's the most common malignant tumor of salivary gland. What is the second most common malignant tumor of salivary gland? Adenoid cystic carcinoma. And you know, adenoid cystic carcinoma is the most common malignant tumor of minor salivary gland, submandibular gland, sublingual gland. Okay, for all these is the most common malignant tumor. Now, what is the most common site? The most common site of adenoid cystic carcinoma is the hard palate, followed by sinonasal tract. Sinonasal tract. What is the most common type? It is cribriform variety. This is asked in pathology also. Cribriform variety, and this cribriform variety is having Swiss cheese pattern. Cribriform variety is having Swiss cheese pattern, right? There are two important properties of this tumor. First, it is having perineural invasion. Important property. In adenoid cystic carcinoma, there is perineural invasion and there is skip lesions. Presence of what? Skip lesions. Now comes the question, if there is perineural invasion, which nerves are most commonly involved? So it is related to head and neck, especially related to face. So which two nerves are mainly related to face? Yes, obviously face, facial nerve. So most commonly involved nerve, facial nerve. And the second is what? Trigeminal nerve. So it's facial followed by trigeminal nerve. Okay, so there is perineural invasion and there are skip lesions. If there is perineural invasion, so what is the manifestation? Obviously, these patients will be having pain. There is involvement of facial nerve. So what will happen? There is facial nerve paralysis. There can be pain, there can be facial nerve paralysis. Important point. Second, it is known as trachyerus tumor. Why it's known as trachyerus tumor? Because this tumor appears benign, but actually speaking it's malignant. Tumor is malignant, but it appears benign, so it's known as trachyerus tumor. Another important property, it's having high risk of distant metastasis. This was the question in AIIMS. And what's the most common site of distant metastasis? It's lungs. It's lungs. How we are going to make the diagnosis? So we discussed that for salivary gland tumors, investigation of choice for diagnosis is FNAC. Now see the twist in the question. Radiological investigation of choice for detection of what? Early perineural spread, and along the nerve there is intracranial extension. So what's the radiological investigation of choice for? Detection of early perineural spread and intracranial extension, and obviously you know the answer. What? It's MRI. It is MRI. We discussed that the tumor is having skip lesions, right? Since the tumor is having skip lesions, we have to take this precaution in the excision of tumor. What? That whenever we are excising the tumor, we are going to take widest cuff of normal tissue around the tumor. widest cuff of normal tissue around the tumor is removed. Why? Because there is presence of skip lesions. Because of skip lesions, there is increased risk of recurrence, and that's why in post-operative period, what should be given? Radiotherapy. So it's the excision with widest excision of normal tissue around the tumor. Along with that, we give post-operative radiotherapy in adenoid cystic carcinoma. See the important anatomical relations of submandibular gland. Here you can see there is a nerve, and this nerve, it's going to hook what? Submandibular duct. Can you see here? Yes, submandibular duct is being hooked by lingual nerve 1, and there is a second nerve in relation to this submandibular gland, that is hypoglossal nerve. These two questions are asked indirectly. Question that in submandibular gland surgery, what are the two nerves most commonly injured? So most commonly injured is lingual followed by hypoglossal. Lingual followed by hypoglossal. One question. Second question, that this lingual nerve is going to hook the submandibular gland, and because of that, it's one of the cause why stones are most common in submandibular gland. In silolithiasis, stones are most commonly seen in submandibular gland. One reason is that the duct is hooked by lingual nerve. Now see other structures which are in relation to submandibular gland. One is marginal mandibular branch of facial nerve, facial artery, and anterior facial vein. Facial artery and anterior facial vein. So what are the important structures related to submandibular gland? We discussed lingual nerve, hypoglossal nerve, marginal mandibular branch of facial nerve, facial artery, and anterior facial vein. Now we are going to discuss salivary gland stone, which is also known as silolithiasis. So we discussed 80% of salivary gland stones are seen in which gland? Submandibular gland. One of the reason was that duct was hooked by lingual nerve. And 80% of salivary gland stones are radiolucent or radiopaque. We discussed it's radiopaque. Okay. See the composition. So it is composed of calcium oblique magnesium phosphate oblique carbonate. Is the calcium oblique magnesium phosphate oblique carbonate. Phosphate oblique carbonate. Now see the problem because of stone. If the stone is there in the submandibular duct, what is the problem? Whenever patient is having meals, there is swelling and pain in the upper part of neck, especially in the submandibular region. One thing. Second, because of presence of stone in the submandibular duct, sometimes there is irritation of lingual nerve, and if there is irritation of lingual nerve, there is pain referred to tongue. So referred pain to tongue. Second, there is pain and swelling in the submandibular region. This is radiopaque stone. How we are going to make the diagnosis? Investigation of choice for diagnosis is NCCT. It's NCCT. Treatment easy. If stone is present in the duct, we give incision over the stone, remove the stone. Second problem, if the stone is located in the gland, we have to excise the gland. So stone in the duct, incision over the duct, removal of stone. And if the stone is located in the gland, we have to go for gland excision. In this image you can see this bluish swelling in relation to frenulum located in the floor of mouth in relation to which gland? Sublingual gland. It resembles frog's belly. What's the name? It's ranula. Because appearance is bluish, it resembles frog's belly. You know, ranula can be mucus extravagation cyst also. It can be retention cyst also. Most commonly, it is mucus extravagation cyst. You have to remember, it's wrongly given in Bailey. Most commonly, it is mucus extravagation cyst in relation to which gland? Sublingual gland. Generally, it's unilateral, located in the floor of mouth. So how we are going to make the diagnosis of ranula it's the clinical diagnosis on the basis of appearance, means on the basis of appearance of this lesion, bluish appearance, unilateral, located in the floor of mouth very close to frenulum. How we are going to treat? So in the ranula, you give incision over the cyst. Okay, so you divide the wall, and after dividing the wall, you are going to suture the edges of wall to the surrounding tissues. So here you can see it is sutured to the surrounding tissues. Clear? And what's the name of this surgery? This is known as marsupialization. This is marsupialization. Sometimes after marsupialization there is recurrence. If there is recurrence after marsupialization, in those cases we go for excision of cyst. So what's the treatment for ranula? Marsupialization. If there is recurrence after marsupialization, we go for excision. In this image you can see there is intraoral ranula with cervical prolongation. Can you see here? Intraoral ranula with cervical prolongation. This is known as plunging ranula. We discussed ranula can be mucus extravasation or it can be retention cyst also, but most commonly it's mucus extravasation cyst. This plunging ranula, it's plunging ranula, and this plunging ranula, it's exclusively mucus extravasation cyst. Obviously, it is arising from which gland? Arising from sublingual gland, right? So important image based questions are asked in relation to ranula. So this is all about salivary glands. Now we are going to discuss important topics related to neck. First is this image. Here you can see the tumor is arising from medial side of carotid bulb. It is known as chemodectoma. Other name of this tumor is carotid body tumor. Since it is arising from carotid bulb, it is also known as non-chromaffin paraganglioma. It's a benign tumor, and in 10% patients there is positive family history. It is related to high altitude. So the patients who are staying at high altitude, there is chronic hypoxia, and because of this chronic hypoxia, sometimes there is carotid body hyperplasia. That's why association is there between carotid body tumor and high altitude. There is another important association. It is associated with pheochromocytoma. Pheochromocytoma. There is an important classification used for carotid body tumor. What's the name? It's Chamblin classification. Name of classification used for chemodectoma. That's Chamblin classification. Okay. Now see how this patient presents to us. Generally, these patients are coming to us with painless mass in relation to neck. This is firm, rubbery, mobile from side to side. It is in relation to carotid vessels, and it's a vascular swelling. You know, vascular swellings are pulsatile. It is compressible, and if you are going to put your stethoscope, there is audible bruit. So three important properties. Because it's a vascular swelling. First, that there is pulsation, so it's a pulsatile swelling. Second, it's compressible swelling. Vascular swellings are compressible, so it's compressible, and there is presence of audible bruit. Swelling is in relation to carotid artery. So what is the investigation of choice for diagnosis? Angiography. Which angiography? Carotid angiography. So this is the finding on carotid angiography. You know, this is internal carotid, this is external carotid. There is a mass or tumor here. So what happens? Whenever there is increase in the size of mass, what happens? There is splaying of carotid, and this splaying of carotid is known as Lier sign. Investigation of choice for diagnosis, it is angiography, carotid angiography, and on angiography the sign is Lier sign. See the treatment. Tumor is benign and it is having slow growth. So if elderly patient is having chemodectoma or carotid body tumor, we only go for observation. Why? Because it's benign and there is slow growth. Whenever the size of tumor is more than 3 cm, we go pre-operative embolization. So in such patients, what's done? It is the pre-operative embolization. If the size of tumor is more than 5 centimeter, in that case, we are going for excision of carotid. Okay, so excision of carotid artery, and after excision we have to put the graft. So it's excision with carotid artery replacement. Carotid replacement whenever the size of tumor is more than 5 centimeter. Name of this condition is cystic hygroma. Name is cystic hygroma, so it is characterized by presence of multiloculated cystic spaces. There is hygroma, so it contains clear fluid. Multiloculated cystic spaces with clear fluid. So this is cystic hygroma. Question in relation to cystic hygroma, that it is associated with Turner syndrome. Turner's syndrome. Okay. Generally, the most common site is in the neck. In this image also, you can say what is the most common site is the posterior triangle of neck. The most common site is posterior triangle of neck. At birth, 50% patients are having this swelling. So cystic hygroma is present at birth in 50% patients. If it is present at birth, so what's the problem? It can cause difficulty in labor. One problem. Second, the good thing is that spontaneous regression is seen in the patients of cystic hygroma. Now coming to the complications. The swelling is in relation to neck, and in majority of cases the big swelling. That's why sometimes it is going to compress the airway. So there can be airway obstruction. Sometimes in the cystic hygroma there is infection or hemorrhage. Infection or hemorrhage. Cystic hygroma is soft and compressible swelling. Another important property, when the child is going to cough or child is going to cry, there is increase in the size of swelling. We discussed meningocele. We discussed that on transillumination, meningocele is brilliantly transilluminant. But cystic hygroma is brilliantly translucent. You have to remember, in certain books it's wrongly written that cystic hygroma is also brilliantly transilluminant. No, meningomyelocele is brilliantly transilluminant, and cystic hygroma, it's brilliantly translucent. You have to remember, it's brilliantly translucent. What is the investigation of choice for diagnosis? So we go for MRI. Investigation of choice for soft tissue hamartomatous malformation like cystic hygroma, like lymphangioma or lymphovenous malformation. Cystic hygroma, lymphangioma, lymphovenous malformations. In all these cases, investigation of choice for diagnosis is MRI. Okay, so diagnosis is done by MRI. What is the treatment? It's the complete surgical excision. The treatment of cystic hygroma is the complete surgical excision. 4 points you have to remember. It is associated with Turner syndrome, most common site, posterior triangle of neck. It is soft, compressible, translucent swelling. Investigation of choice is MRI, and the treatment is complete surgical excision. Branchial cleft remnants were asked many times, both in AIIMS as well as in NEET PG. In toddlers, what's the presentation? There is lateral neck mass. So these are going to present as lateral neck mass in toddlers. Okay. What are the presentations of branchial cleft remnants? It can present as sinus, fistula, cartilaginous rest or cyst. If we see infants, in infants, sinus, fistula, cartilaginous rest, these are more common. So these are common in infants. And if you see older children and adolescent patients, cysts are more common. So cyst, it is more common in older children and adolescents. In older children and adolescents. Okay. Two questions which are frequently asked in relation to branchial cleft remnants. One is branchial cyst and the second is branchial fistula. We are going to discuss one by one. Branchial cyst is the vestigial remnant of second branchial cleft. What? Vestigial remnant of second branchial cleft. You can see this is sternocleidomastoid muscle. This is the lower 1/3. This is the middle 1/3 and this is the upper 1/3. Where is the location of cyst? So it is located at the junction of what? Upper 1/3 location. Junction of upper 1/3 and middle 1/3. This is the location. Generally, branchial cyst, it's lined by squamous epithelium. What? It is lined by squamous epithelium. This is asked in exam. What is the content? So it contains thick, turbid cholesterol crystals. There is presence of thick, turbid cholesterol crystals. Location we discussed at the junction of upper and middle one third. How we are going to make the diagnosis of branchial cyst? So generally the diagnosis is made by FNAC. Ultrasound helps in the diagnosis. So for diagnosis we use both FNAC and ultrasound, and the treatment is surgical excision. So what's the treatment of branchial cyst? It's the surgical excision. This is branchial fistula. This is persistent second branchial cleft. Branchial fistula is persistent second branchial cleft. And what is the lining? The lining is ciliated columnar epithelium. It is lined by ciliated columnar epithelium. Okay. See what kind of discharge is there. So you are going to find either mucus discharge or sometimes there is mucopurulent discharge. Mucus or mucopurulent discharge. This is fistula. What is the definition of fistula? It's the communication between two epithelial lined surfaces. So there is one external opening and there is internal opening. You can see where is the external opening. It is in relation to which muscle? Sternocleidomastoid. Upper one third, middle one third, lower one third. So generally it is located at the anterior border of lower one third of sternocleidomastoid. Anterior border of lower one third of sternocleidomastoid. Okay. Now see, where is the internal opening? So if you see, the internal opening is in relation to palatine tonsil. Okay. Where exactly? It is located at the anterior aspect of posterior fascial pillar. What's the location? Location anterior aspect of posterior fascial pillar. Okay. So in relation to what? Tonsil. It's anterior aspect of posterior fascial pillar. There are two terms. One is branchial fistula and the second is branchial sinus. In certain cases, this internal opening is closed or there is no internal opening. So if it's blind, there is only one opening, then it is known as branchial sinus. If there is no internal opening, it is known as branchial sinus. Important property related to branchial fistula. See the course of fistula. If you are going to notice the course, the fistula passes through the bifurcation of carotid artery. Since it is passing through the bifurcation of carotid artery, in the treatment, we have to give multiple transverse incisions in step ladder pattern. For complete excision, what? Multiple transverse incisions are given in step ladder pattern. So course is through carotid artery bifurcation. That's why surgical excision is done by multiple transverse incisions in step ladder pattern. See the relation of various lymph node levels in the neck. This is 1A, that is submental. This is 1B, it is submandibular. Level 2 is upper jugular, 3 is middle jugular, 4 is lower jugular. Level 5, it is posterior triangular, 6 is central or anterior compartmental, and 7 is superior mediastinal. So in this image you can see this is 1A, that is submental. This is 1B, that is submandibular. This is level 2, which is upper jugular. Level 2 is further divided into 2A and 2B in relation to a nerve. What's the name of this nerve? You can see spinal accessory nerve. So the lymph nodes which are anterior to spinal accessory nerve, that's 2A, and if it's posterior to spinal accessory nerve, it's 2B. Level 3, it is middle jugular. Level 4, it's lower jugular. 5, which is posterior triangular, is further divided into 5A and 5B in relation to which structure? Cricoid cartilage. So here you can see cricoid cartilage. If it is above cricoid cartilage, this is 5A. And if it's below cricoid cartilage, it is 5B. Here you can see level 6, that's central or anterior compartmental, and 7 is superior mediastinal. See the MCQs. You know, in malignancies, there is enlarged left supraclavicular lymph node. This is known as Troisier sign, and the name of lymph node is Virchow's node. Virchow's node are included in which level? Level 4. So in level 4 lymph nodes, these Virchow's level 4 lymph nodes, Virchow's node are included. So these are included in level 4, Virchow's node. After that, you must be knowing Delphian nodes, which are pre-cricoid or pre-laryngeal lymph nodes. So these Delphian nodes are included in level 6. Delphian nodes and Delphian nodes are included in level 6. Another question we discussed in thyroid malignancy. See the location of thyroid. Here is the thyroid. So in thyroid malignancies, which level of lymph nodes are involved? So it is central or anterior compartmental. That's why in thyroid malignancies we go for central lymph node dissection. So level 6, it's the most commonly involved lymph node in thyroid malignancies. Okay, these are one-liner MCQs. There are two types of lymph node dissections which are frequently asked. One is radical neck dissection and the second is modified radical neck dissection. So it is RND, radical neck dissection, and the second is MRND, modified radical neck dissection. In both, we are going to remove which levels of lymph nodes? Level 1 to level 5. So in both level 1 to level 5, lymph nodes are removed. What are the differences? Apart from removal of level 1 to level 5 lymph node, what else is removed? In radical neck dissection, we remove spinal accessory nerve, we remove internal jugular vein, and we remove sternocleidomastoid muscle. So what is removed? Spinal accessory nerve, internal jugular vein, and sternocleidomastoid. In RND, these are removed, but in MRND, these are preserved. If spinal accessory nerve is preserved, this is type 1 MRND. If both spinal accessory nerve and internal jugular vein is preserved, this is type 2. And if all the three structures are preserved, this is known as type 3 MRND. And type 3 MRND is also known as functional neck dissection. It is also known as what? Functional neck dissection. Type 3 MRND. Okay, so you have to remember which structure is preserved in which type of MRND. How to remember types of MRND? Mnemonic is CISP. S, spinal accessory nerve. I, internal jugular vein. SM, sternocleidomastoid muscle. So in type 1, S, this is spared. In type 2, spinal accessory nerve, internal jugular vein is spared, and in type 3, all these three are preserved or spared. Okay, so it is CISP. You can easily differentiate. S is spinal accessory nerve, SM is sternocleidomastoid muscle. So this is MRND. These are important questions in relation to RND and MRND, and this is all about neck. Now we are going to discuss important topics of facial injuries and abnormalities. First of all, we are going to discuss cleft lip and cleft palate. The most common congenital abnormality of orofacial structures include cleft of lip, cleft of alveolus, cleft of lip, alveolus, soft and hard palate, soft and hard palate. Okay, these are the most common congenital abnormalities of orofacial structures. There is one syndrome which is associated with cleft lip and palate, and that is Pierre-Robin syndrome. It is asked in exam, you have to remember the name. Now see the incidence. If we see the incidence of cleft lip plus cleft lip and palate, this is more common, and incidence is 1 in 600 live births. 1 in 600 live births. Isolated cleft palate is relatively less common, and the incidence is 1 in 1000 live births. In majority of patients who are having cleft of, in majority of patients who are having cleft abnormalities, you will find the combination of cleft lip and cleft palate. So what is the most common combination seen in the patients? It's the cleft lip plus cleft palate. See this image. This is unilateral cleft lip and this one is bilateral cleft lip. Here you can see that this is maxillary process. Okay. The upper lip is going to develop mainly from maxillary process. The philtrum is going to develop from medial nasal process. So what happens in cleft lip, which is unilateral, there is non-fusion of this maxillary process and this medial nasal process. So this is medial nasal process. So there is non-fusion of maxillary process and medial nasal process. What else you can notice? This is the alar cartilage. So here there is posterior displacement of alar cartilage. So here you can see there is posterior displacement, right? So there is posterior displacement of alar cartilage, failure of fusion of maxillary process and medial nasal process, and posterior displacement of alar cartilage. What are the problems with cleft abnormality? So in the cleft abnormality, there are two problems. One is feeding problem and the second is breathing problem. So these patients are going to encounter breathing difficulty and feeding difficulty. One question was asked that can we make the diagnosis prenatally or during pregnancy? Yes, even isolated cleft palate. If the patient is having isolated cleft palate, we can make the diagnosis at 18 weeks of gestation. So diagnosis can be made during pregnancy. Isolated cleft palate can be diagnosed at 18 weeks of gestation. Okay. In these cases, in cleft abnormality, obviously we have to go for surgery. So surgery is done for restoration of normal anatomy. So what we have to do? Restoration of normal anatomy. There are named procedures which are asked frequently in relation to cleft lip and palate. The most commonly performed surgical procedure is Millard rotation advancement technique. Most commonly performed is Millard rotation advancement technique. Other procedures are Lee Musserius, Tennyson, Rendall, Thompson. You have to remember the names. Most commonly performed is Millard rotation advancement technique. There is a second group of question which is asked frequently, that at what particular age the repair should be done in patients of cleft lip, cleft palate, and when patient is having both cleft lip and palate. See the timing of repair. If the patient is having cleft lip alone, unilateral cleft lip, so the timing is 5 to 6 months. It's done. Repair is done at 5 to 6 months. And if it's bilateral, we go for one operation done at 4 to 5 months of age. So if it's unilateral, it's done at 5 to 6 months of age. Bilateral, 4 to 5 months of age. In relation to timing of repair, you have to remember one principle. What? That if patient is having cleft lip plus cleft palate, generally the soft tissues are repaired together and hard structures are repaired separately. So if a patient is having cleft lip plus cleft of soft palate and hard palate, we are going to perform two surgeries. Two-stage surgeries are done. So in first surgery, we are going to perform the repair of cleft lip and soft palate. And in the second surgery, we perform the repair of hard palate. Okay. So see, if a patient is having cleft palate alone, this soft palate, if there is cleft of soft palate only, one operation is done, only one operation at 6 months of age. If there is cleft of palate involving only hard palate, what? One operation is done at 15 to 18 months of age. If patient is having both cleft of soft palate and hard palate, so obviously the cleft of soft palate is repaired at 6 months of age and hard palate is repaired at 15 to 18 months of age. The third situation is when the patient is having both cleft lip plus cleft palate. Okay, if it is unilateral, at what age the repair of cleft lip and soft palate should be done? So we discussed it is 5 to 6 months. 5 to 6 months. And if it is hard palate, obviously it is 15 to 18 months as we discussed before. right? If there is bilateral cleft lip plus palate, so relatively the repair should be done relatively earlier. So here, cleft lip and soft palate, the surgery is done at 4 to 5 months of age, right? And for hard palate, it is same, what, 15 to 18 months. So this is the timing you have to remember. It's very, very easy to remember. Cleft lip, 5 to 6 months. If it is bilateral, 4 to 5 months. Cleft palate, hard palate at 15 to 18 months, and soft palate, the surgery should be done at 6 months. So this is very, very important. You have to remember the timing of repair. Mid-face fractures involving maxilla is known as Lee-Ford fracture. And this Lee-Ford fracture is further divided into Lee-Ford 1, Lee-Ford 2 and Lee-Ford 3. If you see this Lee-Ford 1, here the fracture line runs above and parallel to palate, and it separates alveolus and palate from facial skeleton. Okay, see the Lee-Ford 2. Here you can see this is Lee-Ford 2. Okay, see the Lee-Ford 2, shape of Lee-Ford 2 is pyramidal, and you can see here the fracture line passes from root of nose, lacrimal bone, orbital floor or floor of orbit, maxillary sinus, which part, upper part, and pterygoid plate. So here you can see root of nose, lacrimal bone, floor of orbit, upper part of maxillary sinus and pterygoid plate. Now see the Lee-Ford 3. In the Lee-Ford 3 fracture, you can see that there is complete disjunction of this facial skeleton from skull, and the fracture line passes through nasal bridge, septum, ethmoid, bone of orbit, and frontozygomatic suture. Clear? So these are the important properties of Lee-Ford 1, Lee-Ford 2, Lee-Ford 3. So let's revise quickly. In Lee-Ford 1, the fracture line passes above and parallel to palate, and here you can see the alveolus and palate, these are separated from facial skeleton. In Lee-Ford 2, if you see, the shape is pyramidal, and here the fracture line passes through nose, lacrimal bone, orbital floor, upper part of maxillary sinus, and what, pterygoid plate. So how to remember? The mnemonic is nose, lao, maxilla pe. Fracture line passes through nose, lao, maxilla pe. So nose, LA means lacrimal bone, O means orbital floor, maxilla means maxillary sinus, pe means pterygoid plate. Now see this Lee-Ford 3. So see Lee-Ford 3, this is skull, and you are going to notice that there is complete disjunction of facial skeleton from skull, and here the fracture line passes through nasal bridge, septum, ethmoid, orbit, and this suture is frontozygomatic suture. So how to remember? The mnemonic is NSC of Z. N means nasal bridge, S means septum, E means ethmoid, O means orbit, FZ, this is frontozygomatic suture. So these are the important properties of Lee-Ford 1, Lee-Ford 2, Lee-Ford 3, which is frequently asked in exam. So this is all about facial injuries and abnormalities. Now we are going to discuss oncology. First, we are going to discuss the one-liner questions related to soft tissue sarcoma. So first question, what is the most common type of soft tissue sarcoma? And you know, it is liposarcoma. This is liposarcoma followed by leiomyosarcoma. Leiomyosarcoma. Most common type of soft tissue sarcoma, liposarcoma followed by leiomyosarcoma. What is the most common soft tissue sarcoma in extremities? And that is malignant fibrous histiocytoma. You see, what is the most common type of soft tissue sarcoma in children, or most common type of pediatric soft tissue sarcoma? And you know, it is rhabdomyosarcoma. There was one question in AIIMS. The question was, what's the most common retroperitoneal tumor? Or the question is, what is the most common type of retroperitoneal sarcoma? And obviously it is what? Liposarcoma. It is liposarcoma. If you see the site of soft tissue sarcoma, so what is the most common site of soft tissue sarcoma? The most common site is extremity Okay, and in extremities, which extremities are commonly involved? You have seen it's the lower extremity followed by upper extremity, lower extremity followed by upper extremity. So extremities followed by trunk followed by retroperitoneum followed by head and neck. So extremities followed by trunk followed by retroperitoneum followed by head and neck. So these are related to the most common type and most common site. Now coming to the route of spread, we discussed that in carcinoma, what is the most common route of spread? It is lymphatic. And in sarcoma, what is the most common route of spread is hematogenous. So in soft tissue sarcoma, the most common route of spread is hematogenous. And because of this hematogenous spread, what is the most common site of metastasis? It's the lungs. So in soft tissue sarcoma, most common site of metastasis is lungs. Now see the twist in the question. If the location of soft tissue sarcoma is in the retroperitoneum, the most common site of metastasis is liver followed by lungs. So read the question carefully. It's the liver followed by lungs. In sarcomas, we discussed that lymphatic spread is usually not seen, but there are exceptions. So there are 6 sarcomas which are associated with lymphatic spread. What are those? So how to remember? The mnemonic is MARSES. Okay. So these are the sarcomas which are associated with lymphatic spread. If there is lymphatic spread, it means there is lymph node metastasis. And if there is lymph node metastasis, what is required in surgery? Lymph node dissection. So there are 3 questions which are asked in relation to these sarcomas. What are the sarcomas associated with lymphatic spread, sarcomas associated with lymph node metastasis, or sarcomas in which we perform the lymph node dissection? So MARSES, M means malignant fibrous histiocytoma, A means angiosarcoma, R means rhabdomyosarcoma, C means clear cell sarcoma, E means epithelial sarcoma, and S is synovial sarcoma. Now see the questions related to diagnosis. First question, what is the investigation of choice for diagnosis of soft tissue sarcoma? And you know, it is biopsy, which is also known as true cut biopsy, which is also known as core cut biopsy. So biopsy, true cut or core cut biopsy. This is for the investigation. It is soft tissue sarcoma. So to assess the extent of soft tissue sarcoma, what is the investigation of choice? And that's MRI. Now twist, if it's in retroperitoneum, patient is having retroperitoneal sarcoma and we want to assess the extent, what is the investigation of choice? CCT. It is CCT. So in general, to assess the extent of soft tissue sarcoma, what is the investigation of choice for diagnosis? And that's MRI. Now coming to the prognostic factors, we discussed many times that most important prognostic factor in most of malignancies is stage. Why? Because this stage includes T and M. So most important prognostic factor for most of the malignancies is stage. There are 2 exceptions. In Wilms tumor, we discussed in Wilms tumor, what's the most important prognostic factor? And that's histology followed by stage. And another important point, in soft tissue sarcoma, what's the most important prognostic factor? And that's tumor grade. It's tumor grade. Okay. Now the question, most important prognostic factor in soft tissue sarcoma is tumor grade. What is the most common cause of death in soft tissue sarcoma? And the most common cause of death is metastasis. In soft tissue sarcoma, the most common cause of death, and that is metastasis. Clear? So these are one-liner questions related to soft tissue sarcoma. Now we are going to discuss soft tissue sarcoma in detail. So in soft tissue sarcomas, the most common histopathological type is site dependent. So if you see extremities, what is the most common type of soft tissue sarcoma? That is malignant fibrous histiocytoma. In retroperitoneum, we discussed most common type is liposarcoma, and in the viscera it is gastrointestinal stromal tumor. Now see the clinical features. If you have seen a case of soft tissue sarcoma, you must be knowing that the most common presentation of soft tissue sarcoma is the painless mass. What kind of mass? It's the painless mass. If we see, the size of mass depends on the location of tumor. If you see the tumor which is located in distal extremity, tell me these are larger or smaller? So the soft tissue sarcomas located in distal extremities, these are relatively smaller. Okay, and if the tumor is located in proximal extremity or tumor is located in retroperitoneum, these are larger. So size at the time of presentation depends on the location. Now the basic things which we discussed about diagnosis, that investigation of choice for diagnosis is true cut biopsy or core cut biopsy. Investigation of choice to assess the extent of soft tissue sarcoma, MRI. Investigation of choice to assess the extent of retroperitoneal sarcoma, CCT. Clear? Now coming to the treatment. In soft tissue sarcomas, what's the treatment? We go for surgery, we give radiotherapy, we give chemotherapy. Okay, so in surgery, what's the treatment option? We go for wide local excision with 2 centimeter margin. Wide local excision with 2 centimeter margin. For radiotherapy, we have two options. One is external beam radiotherapy, and the second is intensity modulated radiotherapy, IMRT. And for chemotherapy, we use two agents commonly. One is doxorubicin and the second is ifosfamide. So what are the agents used? It's doxorubicin and the second is ifosfamide. Clear? So the treatment includes wide local excision, radiotherapy as well as chemotherapy in soft tissue sarcoma. We discussed what's the most common type of pediatric soft tissue sarcoma, and that is rhabdomyosarcoma. In rhabdomyosarcoma, what is the most common site? It is head and neck, especially it's parameningeal. So the most common site, it's head and neck, and what's the exact location? It's the parameningeal. See the important questions related to pathology in rhabdomyosarcoma. First, what's the most common histological type? And that is embryonal rhabdomyosarcoma. That is embryonal rhabdomyosarcoma. What is the most common histological type in adults? And in adults, it's pleomorphic variant. So this is which one? Pleomorphic variant. What are the diagnostic cell? So in this rhabdomyosarcoma, there is presence of rhabdomyoblast. Name is rhabdomyosarcoma. So diagnostic cell is rhabdomyoblast. There is presence of tadpole cells and strap cells. Tadpole cells and strap cells. Now see the clinical features. Just like soft tissue sarcoma, in this case also there is painless mass. But what? It is rapidly spreading. So here the most common presentation is rapidly spreading painless mass. Rapidly spreading painless mass. Rest of the behavior is like soft tissue sarcoma, that the most common route of spread hematogenous, most common site of metastasis lungs, investigation of choice for diagnosis true cut biopsy or core cut biopsy, investigation of choice to assess the extent of rhabdomyosarcoma, MRI. It's like soft tissue sarcoma, and the treatment is also like soft tissue sarcoma. Generally, what's the treatment? So here we go for wide local excision. If the tumor is resectable, generally we go for wide local excision with 2 centimeter margin. See this image and tell me the diagnosis. This is very hot topic, and this tumor is DFSP. What is the full form? It is also known as dermatofibrosarcoma protuberans. What's the name? It's dermatofibrosarcoma protuberans. Okay, and the term is self-explanatory. First, dermato. Okay, so it is going to involve what? Dermis and subcutis. Dermato, it involves dermis plus subcutis. It is fibrosarcoma. It's a type of low-grade sarcoma. What type? Low-grade sarcoma. And if you see the level of lesions, there is protrusion in the lesions. These lesions are above the skin surface. So what? Protuberance. So dermatofibrosarcoma protuberans. What is the most common site? How to remember? The mnemonic is 10. Most common site, it's 10. T means it's trunk, followed by extremity, followed by head and neck. So the most common site is trunk, followed by extremity, followed by head and neck. Now see the special feature of this tumor. If you see this is tumor, and see there is radial extension of this tumor. Because of this radial extension, if we are not going to take sufficient margin during surgery, what will happen? There is recurrence. So how much margin is taken here? We take circumferential margin, and how much? Minimum 2 to 4 centimeter. And we have to excise underlying fascia. So because of this radial extensions or finger-like extensions, we take circumferential margin in excision. How much? 2 to 4 centimeter. What is the presentation? You can see here. So it looks like nodular cutaneous mass. So presentation is nodular cutaneous mass. How we are going to make the diagnosis? Biopsy. What kind of biopsy here? We take incisional biopsy. So in this case, we go for incisional biopsy. And what's the treatment here? The treatment is wide local excision with 2 to 4 centimeter. You have to remember circumferential margin. Circumferential margin. Right? And apart from taking this circumferential margin, we have to remove the underlying fascia. So removal of underlying fascia. Underlying fascia. This is the treatment. At the time of presentation, certain patients are having advanced dermatofibrosarcoma protuberans, or the tumor is unresectable. So we have to downstage the tumor, and what's the first line agent here? It's the imatinib. Imatinib. And if you remember, we discussed that imatinib is drug of choice for unresectable GIST and CML. So here also the first line agent for unresectable DFSP or advanced DFSP is imatinib. So this is how we manage the DFSP. Now we are going to discuss oncological emergencies. First is tumor lysis syndrome. So the term is self-explanatory. It's the syndrome caused by lysis of tumor cells. Means it is caused by destruction of large number of rapidly proliferating cells or malignant cells. Usually when we start chemotherapy, there is destruction of these large number of rapidly proliferating cells. So especially the malignancies in which we are giving chemotherapy. So tumor lysis syndrome is associated with which malignancies? So tumor lysis syndrome is most commonly associated with treatment of high-grade lymphoma, chronic leukemia, ALL and Burkitt's lymphoma. And generally you notice that in these cases we give chemotherapy which leads to rapid destruction of cells. How to remember? The mnemonic is HiGCAB. HiGCAB. High-grade lymphoma. C means chronic leukemia, A means ALL and B means Burkitt's lymphoma. Now it's very easy to understand the pathophysiology and management. Because of destruction of malignant cells, there is rapid turnover of nucleic acid. And whenever there is rapid turnover of nucleic acid, what will happen? This hypoxanthine will be converted into xanthine, and xanthine will be converted into uric acid. So what's the biochemical abnormality? This patient will be having what? Hyperuricemia. First problem, hyperuricemia. Second, because of cellular destruction, there is release of intracellular potassium. And if there is release of intracellular potassium, patient is having hyperkalemia. Hyperkalemia leads to arrhythmias. Release of intracellular phosphate also, and because of release of intracellular phosphate, there is hyperphosphatemia. Hyperphosphatemia. What is the problem? Because of this hyperphosphatemia, this phosphate is going to combine with calcium, and if it combines with calcium, what's the effect? Yes, there is hypocalcemia. Calcium level will be decreased, so its effect is hypocalcemia, and this calcium phosphate is deposited in the renal tubules, and because of that, what will be the problem? There is renal failure. There is renal failure, and if there is deranged oxidative metabolism, in this case there is lactic acidosis. Lactic acidosis. Right? So what you saw here, what are the dyselectrolytemias seen in tumor lysis syndrome? Hyperuricemia, hyperkalemia, hyperphosphatemia. All these are increased. Only calcium level is decreased. So there is hypocalcemia. Okay, this is the abnormality. How to manage? It's very easy. So hyperuricemia, for this we can give allopurinol or rasburicase. Allopurinol or rasburicase is given for hyperuricemia. Hyperkalemia, for that we are going to manage it with calcium gluconate if patient is having arrhythmia. If patient is having renal failure, there is deposition of calcium phosphate. So here we go for hydration. If there is no improvement, patient is having renal failure, another option is hemodialysis. So rapid hydration, hemodialysis for renal failure. And if patient is having lactic acidosis, we give sodium bicarbonate. So this is how we manage the patients of tumor lysis syndrome. Very, very easy to remember. You know that most of the things are raised, calcium level is decreased. So there is hyperuricemia, hyperkalemia, hyperphosphatemia, but there is hypocalcemia. Next is hypercalcemia of malignancy. First question, what's the most common cause of hypercalcemia of malignancy? And it's because of increased secretion of parathyroid hormone related peptide. So this is because of increased secretion of PTHRP. What are the main factors responsible for hypercalcemia? So there is increased release of calcium from the bone, and there is increased calcium resorption from DCT, that is distal convoluted tubule. So increased release of calcium from the bone and increased calcium resorption from DCT are responsible. So how we are going to manage the patients who are having hypercalcemia of malignancy? In these patients, first we go for rehydration with normal saline, followed by forced diuresis with furosemide. Okay. So this is the emergency management. So what's the management? It is rehydration with normal saline with forced diuresis with the help of furosemide. Apart from this treatment, there are certain drugs which are used to decrease or lower the calcium levels. So what are those drugs? We use bisphosphonates. So in bisphosphonates, what's the drug of choice? And it's the zoledronic acid. This is the zoledronic acid. We can use calcitonin, we can use plicamycin, that's also known as mithramycin, gallium nitrate. We can use glucocorticoids. Which one is used? It's the hydrocortisone. Yes, so in bisphosphonates, the drug of choice is zoledronic acid. Generally, in these patients, we go with forced diuresis after rapid hydration. Next oncological emergency is typhlitis, and this typhlitis also known as neutropenic colitis. Where is the site of inflammation in typhlitis? It's the cecum. Mainly cecum, sometimes ileum is also involved. So that's why what's the name? Cystitis, also known as ileocecal syndrome. Now the term is self-explanatory. See what are the other names used for typhlitis. It's known as neutropenic colitis or necrotizing colitis. It means it's a type of colitis in which patient is having neutropenia. So what's the cause of neutropenia? Generally these patients have malignancy, and for that malignancy these patients are receiving what? Chemotherapy. Because of chemotherapy, these patients are going to develop what? Neutropenia, and going to develop the inflammation. So generally this typhlitis or neutropenic colitis, it is more common in children who are receiving the chemotherapy. So for which malignancies? These children are having AML or ALL. Okay. Whenever there is inflammation of cecum or there is involvement of ileum, so what are the clinical features in these patients? Since there is involvement of cecum and sometimes ileum, there is inflammation, so there is fever, there is right lower quadrant tenderness, and there is diarrhea. What kind of diarrhea? Bloody diarrhea. So these are the clinical features. There is fever, there is right lower quadrant tenderness, and there is bloody diarrhea. There is involvement of cecum. So if we go for ultrasound or CT, what you are going to find, there is thickened cecal wall. What? Thickened cecal wall. Okay. There is inflammation. Okay. There is neutropenia. So in majority of cases, what is sufficient? Medical management is sufficient. So what are the indications of surgery in typhlitis? If there is no improvement within 24 hours of antibiotic treatment, or patient developed perforation. So these are the indications of surgery in typhlitis. Now we are going to discuss superior vena cava syndrome. So what is going to happen in superior vena cava syndrome? In this case, there are clinical manifestations of superior vena cava obstruction. And because of this superior vena cava obstruction, there is severe reduction in the venous return from head and neck and upper extremity. Okay. So see the location. In this, you can see this is the tumor. Where is the tumor? You can see it is located very close to superior vena cava in relation to lungs. So one question is clear. First, that what's the most common malignancy responsible for superior vena cava syndrome? It's the carcinoma lung. Carcinoma lung, it's of two types, central tumors and peripheral. So which one is responsible? You can see central. So there is a tumor here, you can see, and this tumor is compressing what? The superior vena cava. So tumor is compressing superior vena cava, is the central tumor. So first question, what's the most common tumor responsible for superior vena cava syndrome? Carcinoma lung, which one? Small cell lung cancer followed by squamous cell carcinoma. First question, most common cause? Carcinoma lung, small cell lung cancer followed by squamous cell carcinoma. And in young adults, what's the most common cause in young adults? And that's malignant lymphoma. It's the malignant lymphoma. Simple. It's very easy to understand the clinical features. So this tumor is compressing the superior vena cava. That's why the venous return from head and neck and upper extremity is reduced. That's why this patient is having facial puffiness, edema, there is nasal stuffiness. Because of this nasal stuffiness, there is epistaxis, there is swelling around the eyes, there is upper extremity edema. There will be collection of what kind of blood? Deoxygenated. So these patients will be having what? Cyanosis. So in this picture, you can notice that there is edema of face, neck, upper chest, and bluish discoloration. So this is cyanosis. Another thing you are going to notice what? That there is distended veins over the neck, upper extremity, and the lateral chest wall. Why? Because if patient is having superior vena cava obstruction for long duration, there is formation of collaterals between inferior vena cava and superior vena cava. So because of these collaterals, you are going to notice that yes, there are presence of dilated veins over the lateral chest wall, anterior part of chest, upper extremity, and the neck. So this is the presentation. Certain tumors which are advanced, yes, In that case, there is compression of midline structures. And if there is compression of midline structure, involvement of trachea, dyspnea, involvement of esophagus, dysphagia, involvement of recurrent laryngeal nerve, hoarseness of voice. So this is the presentation. What? Edema, nasal stuffiness, swelling around eyes, cyanosis, and presence of dilated veins over anterior part of neck and chest wall. Now how we are going to make the diagnosis? Here the tumor is located in the mediastinum. So what's the investigation of choice for diagnosis? It is CCT. Investigation of choice for diagnosis of superior vena cava syndrome, CCT. If we go for chest X-ray, there is widening of superior mediastinum. So on chest X-ray, you are going to notice widening of superior mediastinum. So there is widening of superior mediastinum on chest X-ray. If we see the treatment is dependent on the underlying cause. If the patient is having non-small cell lung cancer or metastatic solid tumors, in these patients we give radiotherapy. If the patient is having small cell lung cancer or patient is having lymphoma, in these patients we give chemotherapy, and for rest of the patients we go for surgery. So the treatment of superior vena cava syndrome is dependent on the cause, and this is how we treat superior vena cava syndrome. So this is all about oncology.